इंडेक्स होते हैं और फिर कंटेनर के 50% समान जरा ठीक निकला 50% जरा वो आई थिंक वो समझो कि फ्री देने वाला होता है स्क्रैप देने वाला होता है और भी जो 50% निकला सही ना वो भी सारे पूरे पैसे करने हां ये भी ਹੁੰਦਾ नहीं पर दूसरा नहीं था बड़े बैठ यार ये भी जितने अकबर हुई है खरीदे ना डॉक्टर साहब ये तो बंदे के रखे हुए हैं बंदे आप तो
शुरू करें अरशद Gente, faz da nacional. Quero mandar. Vamos ali, Zoom meeting aqui é muito bom. Password.
हेलो अतीक।
हेलो अस्सलाम वालेकुम, क्या हाल है?
वालेकुम अस्सलाम।
शुरू करें? 9:30 शुरू नहीं करनी?
हाँ 9:30 शुरू करनी है, वो पाशा का इंतजार है मेरे ख्याल में।
मैं आ गया हूँ यार, इंतजार की जरूरत नहीं है।
सर बिस्मिल्लाह करें। वालेकुम
9:30 बजे शुरू करनी है कि 10 बजे शुरू करनी थी? 9:30 बजे हमने ऑनलाइन होना था।
हाँ
अभी हम 9:30 बजे ऑनलाइन होके हर एक को ना ये जो से होते हैं, जब ऑनलाइन होते हैं तो फिर उसके बाद सेटिंग्स वगैरह करनी होती हैं।
ठीक है,
तो सेटिंग्स मैं करता हूँ ना।
हाँ बिस्मिल्लाह। हम ऑनलाइन है, तुम सेटिंग करो।
Recording in progress.
सर रिजवान साहब नए वाली मीटिंग शुरू की नए वाली
अस्सलाम वालेकुम एवरीबॉडी। अस्सलाम वालेकुम सर।
वालेकुम अस्सलाम जी, क्या हाल है आपके? ठीक हैं
सर
सर जी ने कही
हाँ हाँ जी
भाई क्या हाल है आपके? डॉक्टर अजीजुल्लाह आप सुन रहे हैं हमें?
जी जी सर मैं सुन रहा हूँ आपको, आपकी जियारत भी कर रहा हूँ, बड़ी मेहरबानी सर, मैं खैरियत से हूँ, वही मैं
आप
बता
ठीक है
रहा था
भाईजान?
आपके लिए। जी सर अल्हम्दुलिल्लाह।
अस्सलाम वालेकुम डॉक्टर मजहर। अस्सलाम वालेकुम डॉक्टर मजहर।
रिजवान कैसे हैं आप? ठीक हैं
जी अल्लाह का शुक्र, आप खैरियत से हैं? ठीक है
अल्लाह का एहसान। किधर बैठे हुए हो? गेट के अंदर?
मैं इधर, हाँ जी, जनाब से कनेक्टेड हूँ आपके साथ जनाब।
वाह जी दैट्स गुड। इसका मतलब है स्पाइन में वाकई आपकी स्पाइन में इंटरेस्ट जो है ना वो बढ़ गई है, हैं?
आप 3 इयर्स के तवस्सुल से
Good. That's good.
सफाई कम न थियो माना सफाई जब बेकार
फरुख भाई सलाम हो गया।
वालेकुम जी, अस्सलाम वालेकुम।
कैसे हैं आप? ठीक है?
अल्हम्दुलिल्लाह। फ्रॉम गिलगित।
अस्सलाम वालेकुम फरुख भाई कैसे हैं?
मैं तुम्हें देख नहीं पा रहा। वालेकुम सलाम। आशा साहब आपकी आवाज बंद है फोन पे।
Morning, Dr. Farooq. Good morning, Dr. Farooq.
गुड मॉर्निंग मुतालिब, हाउ आर यू?
I'm very well, thank you. I'm in the OT.
You are in the OT. Oh, good.
Yeah.
Which OT you are?
Ghurki. I'm actually I'm at the seminar room.
Which room?
The seminar room.
Seminar room.
Premises, you know, nearby. Surely, when we end the meeting, we will meet. अब्दुस्तार, आप कैसे हैं?
सर अल्लाह का शुक्र है, बिल्कुल ठीक हूँ।
ठीक है, आपकी तस्वीर हमें नजर नहीं आ रही, मुबारक चेहरा दिखाएं।
मैं सर अभी दिखाता हूँ आपको।
भाई कैसे हैं आप? ठीक हैं? खैरियत से हैं? I also hope you don't mind because I shared the link with
पाकिस्तान
the
में हो
Spine
क्लीन
Society members in Nigeria, sir. जी सर, पाकिस्तान में हूँ सर।
कब जा रहे हो सर? और यूएस कब जा रहे हो भाई?
सर जून के एंड में जा रहा हूँ, 28 को फ्लाइट है।
चलो अल्लाह खैर करे।
थैंक यू सर, थैंक यू।
अस्सलाम वालेकुम।
सर कब आ रहे हैं आमिर साहब?
आमिर साहब कहाँ? इस मीटिंग में?
हाँ मीटिंग में।
मीटिंग में सर अभी आ जाएंगे, मेरे ख्याल 10 बजे तक आ जाएंगे।
अच्छा अच्छा अच्छा। सर मेरा बेटा पैदा हुआ है।
किसका?
मेरा।
अच्छा माशाल्लाह माशाल्लाह। बच्चे को कब?
सर 4-5 दिन हो गए सर।
ओए होए होए, क्विक। ये तूने लिखा हुआ है ना, क्विक।
बिग सर। सर मैं जरा उसको दिखा के लाता हूँ डॉक्टर के पास। मैं इंशाल्लाह कोई 15-20 मिनट में आप लोगों को ज्वाइन करूंगा।
ठीक है ना वो?
हाँ ठीक है सर, थोड़ा सा आज गला खराब है, फिटिंग के इश्यूज आ रहे हैं, तो बस
हाँ,
उनको
हाँ।
मैं जरा डॉक्टर के पास लेके जाना है, पीट्स वाले के पास दिखा के फिर मैं ज्वाइन करता हूँ मीटिंग। ठीक है सर, ओके सर।
कुदरतुल्लाह न्याजी। अब्दुल्ला, अस्सलाम वालेकुम। या यमनी।
नहीं है डॉक्टर, ये है अब्दुल्ला यमीनी।
अब्दुल्ला
अस्सलाम वालेकुम। हेलो रिजवान, आप मेरी बात सुन रहे हैं? हेलो।
अस्सलाम वालेकुम सर, मैं फरूख बात कर रहा हूँ। आपने मेरे ख्याल मेरी वीडियो अभी अलाउ नहीं की, क्योंकि मैं वीडियो अपनी
जी जनाब, मैं आपकी आवाज सुन रहा हूँ।
तो यू कैन
आप अपनी
स्टार्ट।
रिजवान आप अपनी वीडियो ऑन करें।
हाँ हेलो
फरूख,
नबील।
आपकी वीडियो ऑन है?
हाँ लिखा यू कांट स्टार्ट योर वीडियो बिकॉज वीडियो हैज बीन स्टॉप्ड बाय द होस्ट।
मेरे भी ऐसे ही आ रहा है कि आई कांट स्टार्ट वीडियो बिकॉज द होस्ट हैज डिसेबल्ड इट।
अच्छा चलें ठीक।
ये आप जब तक आपने डिसेबल की होगी तो वो मैं ऑन नहीं कर सकता, आपने ऑन करनी है।
वीडियो कहाँ पे आ रहा है ये नबील?
होस्ट ने करनी है ना फरूख, आप होस्ट हो ना?
हाँ जी
नहीं, बस एक सिर्फ पाशा होस्ट है मेरा ख्याल है। आप
हाँ जी
उसको
हाँ
ना
जी।
फर्रुख को को होस्ट, पाशा आप उसको ना फर्रुख को भी को होस्ट कर सकते हैं।
ठीक है, मैं फरूख को मेक होस्ट कर रहा हूँ।
हाँ, होस्ट करेंगे तो वो को होस्ट ही आएगा ना आपके साथ।
नहीं,
यू
मैंने
कैन
होस्ट
ऐड।
कर दिया उसको। हाँ
चलो
होस्ट
जो
आ गया ना। रिजवान मैं आपको भी कर रहा हूँ, लेकिन
नहीं,
अब आप
चलो
लेकिन ये नहीं, ये मसला ये है ना कि होस्ट कर रहा हूँ तो उनकी वीडियो आई है, अगर होस्ट नहीं करूंगा तो
नहीं नहीं
बिल्कुल
नहीं
नहीं वीडियो आएगी।
नहीं नहीं, आप अगर उसको वैसे ही ऑन करेंगे तो वीडियो, अगर यहाँ से आप क्लिक
वीडियो
करेंगे
हो
वीडियो
जाएगी।
को तो ऑन हो जाएगी।
नहीं हो रही है ये, उसको नबील के दे रहे हैं साहब। फरूख अब हो गया ना होस्ट। फरूख आप देखिए। अच्छा ठीक है, आप ठीक है, आप अब आपने अपना कैमरा ऑन कर लिया ना, आप ठीक है।
जी मैं होस्ट हूँ, मैं कैमरा भी हूँ।
फरूख आप अब ऐड कर लें फिर बाकी लोगों को।
नहीं तो आपने अपना आप होस्ट खत्म हो गए।
जाहिर है अगर मैंने फरूख को होस्ट कर दिया तो मैं होस्ट खत्म हो गया हूँ। होस्ट तो एक ही हो
तो
सकता है।
नहीं, जितने मर्जी ऐड करें, दो करें,
होस्ट
तीन करें।
ना सारा सारा आपने सीखा हुआ है, वो मेरा तो कल नहीं हो सका था, उसमें लैपटॉप नहीं था। आप अपना पहले होस्ट कर लें, क्योंकि आप वो मॉडरेटर भी हैं।
आप दोबारा मुझे होस्ट बना दें फिर।
ये कैसे
ये
बनाना सर?
नबील
ये
से
मुझे
बात करनी है। उसी पर जाएंगे आप, ये राइट वाली विंडो खोलें।
हाँ जी खुली हुई है।
अच्छा उसके ऊपर मेरे वो जो कैमरा है उस पर क्लिक करें।
बन गए आप होस्ट सर, ये
हाँ,
लें। यू
हाँ
आर
ये बन
होस्ट।
गया, लेकिन हाँ, अब आपका आ रही है, ठीक है अब आपका आ रहा है लेकिन।
आप होस्ट बन गए हैं सर।
ठीक है ठीक है। अच्छा आप मुझे देखने दें, मुझे रिजवान का पहले देखने दें। लेकिन रिजवान के जब मैं उस पर जाता हूँ ना,
है बड़ा मसला है सर।
वो लड़का किधर है, आईटी वाला?
ये पिन कर रहा है ना, क्या कहते हैं, वीडियो को ऐड नहीं हो रहा।
फर्रुख उसको बुलाओ ना आप, आईटी वाले लड़के
नबील
को
को
इधर ही
बुलाएं।
बैठ।
नबील को, हेलो
नबील को कॉल कर रहे हैं सर, ये
नबील,
इब्राहिम
नबील को मैं कॉल कर रहा
साहब।
हूँ। अच्छा लेकिन नबील, ये होस्ट मैं हूँ लेकिन मैं अलाउ किसी को कर रहा हूँ तो हो नहीं रहा।
है बड़ा मसला है।
फर्रुख अपने को
ये
बुला लेना।
देखिए कहाँ प्रॉब्लम है।
नबील को सर।
हाँ, इधर ही बुला लो।
जी मैं बुला, ओ सर कॉल कर लें, फिर मैं बंद होगी इसकी कॉल।
वीडियो अलाउ नहीं हो रही। वीडियो अलाउ
तो
करता हूँ तो पिन आ जाता है ना उसमें सिर्फ। आज टू, एक मिनट ठहरें।
है 10 बजे तक क्या ही
देखिए मैं
मसला है।
अगर उस उनकी पे करता
कोई
हूँ
इसी
चैट, पिन मेक होस्ट आ जाता है, रीनेम आता है, पिन इन वेटिंग रूम आता है और रिमूव आ जाता है।
गलत गलत गला आ रही है। चलो म्यूट कर लिया।
ये देखें क्या प्रॉब्लम क्या है। आप खुद होस्ट बन के जरा देखें, होस्ट बन के सेटिंग सही कर दें हमें।
मैं
उसको
उसको
कहो
बुला,
मौजूद रहे ना ऑनलाइन, उसको कहें
मैं अपने
ऑनलाइन मौजूद रहे
होस्ट बन
वहां
के,
पे।
वो ऑनलाइन है, घुरकी ट्रस्ट टीचिंग हॉस्पिटल के नाम से वो होस्ट बन गया है खुद ही।
उसको कहो फिर, इधर सुन नहीं रहा,
देखिए ना
आवाज नहीं आ
मजहर
रही
की भी नहीं
उसको।
तस्वीर आ रही।
वो हमारी बात सुन रहा है सर, वो अब ऑन कॉल है विद पाशा साहब, ये जो फोन कॉल उसी के साथ कर रहे हैं।
नहीं बेटा मेरी बात सुने ना, कि किसी और की वीडियो चल रही। अब ये रिजवान की वीडियो के ऊपर जब मैं करता हूँ, रिजवान की आपकी वीडियो ऑन है? आप जरा अपनी वीडियो ऑन करें।
नहीं
अच्छा
होती ना।
तभी फिर सॉरी, फिर आपकी वजह से फिर हम वो थोड़ा सा मैं हो रहा हूँ। मैं देखता हूँ और किसी का मैं करके देखता हूँ। सोसाइटी ऑफ स्पाइन सर्जन के नाम से कौन ऐड है?
ये कल भी थे कोई सोसाइटी ऑफ स्पाइन सर्जन के नाम से,
के पास
लेकिन
भी शायद
वो
कोई नहीं है, कैमरा नहीं है। समथिंग इज रॉन्ग समवेयर।
समथिंग
रील एक बार सारा कुछ करेंगे फिर आएगा।
सर ਤੁਹਾਡੇ ਜ਼ਿਹਨ 'ਚ ਵੀ ਕੋਈ ਗੱਲ ਆ ਰਹੀ ਹੈ, ਮੈਂ ਤੁਹਾਨੂੰ ਦੱਸ ਰਿਹਾ। ਜਦੋਂ ਤੁਸੀਂ ਹੱਸ ਰਹੇ ਹੋ ਨਾ ਸਰ, ਮੇਰੇ ਜ਼ਿਹਨ 'ਚ ਵੀ ਆ ਰਹੀ।
ਸਾਡੇ ਪਿੰਡ ਉੱਥੇ ਸਿਨੇਮਾ ਬਣਾਇਆ ਨਾ ਬੰਦੇ ਨੇ, ਤੇ
ਜੀ ਸਰ,
ਪਹਿਲੀ ਫਿਲਮ ਚੱਲੀ ਤੇ ਉਹ ਨਾ ਫਿਲਮ ਪੁੱਠੀ ਚੱਲ ਪਈ। ਤੇ ਉਹਨੇ ਆਪਣੀ ਪੱਗ ਚੁੱਕ ਕੇ ਨਾ ਥੱਲੇ ਜ਼ਮੀਨ ਤੇ ਜ਼ੋਰ ਦੀ ਮਾਰੀ।
मैं समझ गया। ये वीडियो आ गई है तो जिंदगी थोड़ी आसानी भी आ गई है। तुम मिल्क शेक स्ट्रॉबेरी दा पीती जा रहे हो कल्ले कल्ले।
हेलो, मैंने अभी डॉक्टर रिजवान अकरम को की मैंने वीडियो ऑन की है, वो तो अभी
मैंने ऑन कर ली है। देखे मैं आपको नजर आने लग पड़ा हूँ, वीडियो ऑन
हाँ जी हाँ जी।
सर आप रिजवान साहब, आपके ऐसा लग रहा है जैसे आप तो हिल रहे हैं लेकिन पीछे वाली चीजें स्टैटिक है, जैसे तस्वीर लगी हुई है रूम की आपके।
हाँ,
ये ऐसे ही है क्या?
ऐसे ही है।
अच्छा,
ये बड़ा सीन है, तेनू की पता मैं कितने बैठा।
हाँ ये तो मैं देख रहा हूँ।
ਇਹੋ ਜਿੱਦਾਂ ਇਮਰਾਨ ਰਿਆਜ਼ ਖਾਨ ਨਹੀਂ ਰੋਜ਼ ਬੰਦਾ ਲਾਇਬ੍ਰੇਰੀ ਦੇ ਵਿੱਚ।
हाँ हाँ हाँ।
सर मेरी आवाज आ रही है आपको?
हाँ जी आ रही है।
अच्छा सर, अभी मैंने वो सेटिंग ठीक कर ली है। अभी मैंने आपकी वीडियो भी अलाउ कर दी है। अब कहते हुए डॉक्टर मजहर अली की वीडियो ब्लॉक करके दिखा देता हूँ आपको। ये मैंने इनकी वीडियो ब्लॉक कर दी है।
ये ब्लॉक नहीं करनी,
डॉक्टर नहीं, मैं एक चीज बताना चाह रहा हूँ। वो सेटिंग एक थी, वो अनचेक हुई थी, तो मैंने चेक कर दी है। तो अभी मैं डॉक्टर इब्राहिम, प्रोफेसर इब्राहिम को मैं बनाने लगा हूँ होस्ट, तो वो फिर बाकी इन चीजों को देख लेते हैं।
लेकिन आप मौजूद रहो ना इधर ही।
सर मैं 9:30 बजे का मौजूद हूँ और मैं मुसलसल प्रोफेसर इब्राहिम के साथ मैं कांटेक्ट में हूँ।
ठीक है,
हाँ जी
बस ठीक है, वेरी गुड।
मैं ये डॉक्टर इब्राहिम फारूक को मैंने होस्ट बना दी है। बाकी वो
और फर्रुख को भी को होस्ट कर देना।
सर फिलहाल एक नहीं हो सकता है एक वक्त में ना,
और नहीं हो सकता, को होस्ट जितने मर्जी कर ले, 3 कर ले, 4।
चले सर मैं इस सेटिंग को देखता हूँ। बहरहाल प्रोफेसर इब्राहिम सर आप देख लें जिनको आप वीडियो अलाउ करना चाह रहे हैं और जिनको आप नहीं चाह रहे वीडियो अलाउ करना।
चलिए ठीक है, मैं कहा पहले काफी लेट हो चुके हैं हम, ठीक है ना? मेरा ख्याल अब शुरू करते हैं। बिस्मिल्लाहिर्रहमानिर्रहीम। अस्सलाम वालेकुम सर। सर आमिर अस्सलाम वालेकुम। So we are going to start this webinar on prolapsed intervertebral disc and different aspects. First of all, I will thank all the faculty and members for sparing their precious time, and I will request Dr. Farooq to recite a few verses from Holy Quran to start the proceeding. Over to Dr. Farooq Bashir.
أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. قل هو الله أحد الله الصمد لم يلد ولم يولد ولم يكن له كفوا أحد. صدق الله العظيم.
Now I request Professor Amir Aziz for opening remarks and introduction. Over to Sir Amir Aziz.
Bismillah ar-Rahman ar-Rahim. Can you all hear me?
Yes, sir.
Yes, sir.
I'm really thankful to Allah, first of all, for giving us this opportunity to act in unison and this is a start of our journey to take the Society of Spine Surgeons of Pakistan together to new heights. Alhamdulillah, I'm very thankful to Professor Imtiaz Hashmi and Dr. Atiq Durrani, who created this Society of Spine Surgeons of Pakistan. And I must thank all the previous office holders who have provided and done their best. But there's a lot still to be done. And inshallah, we will prove equal to the task. We will take it to new heights. We will do everything, inshallah, of international standards. And we are blessed with the AO Spine chapter since the last 12 years. And currently, we are I'm the chairman of the AO Spine Middle East and North Africa. So inshallah, we have a lot of opportunities of fellowships, etc. And it'll all be coordinated through the Society of Spine Surgeons. Before we kick off, I have a very exhilarating announcement to make. Professor Khalid Masood Gondal announced that the FCPS spine has been approved. The nitty-gritty is being sorted out, and inshallah, everything hopefully will be sorted out in the month of June, and by July, we should be able to start this program. What is required of us is to create 450 MCQs, and I would request that these MCQs be of C3 type, so that more mental exercise is being used in it. And inshallah, I hope all of you will create some good quality MCQs, and we will start off. There have been offers from fellowships in different parts of the world. Hopefully, we will, inshallah, be able to get those two for our trainees. We will also, inshallah, start hands-on live surgery programs, but we will ensure that world-class people who are registered are allowed to operate in this country. Unfortunately, in the past, people have been invited and let loose on our patients, and we've had a lot of complications which were hushed up. Inshallah, nothing like that will be allowed, and we will have top quality things. The other announcement is that we have a brilliant consultant spine surgeon from Abuja, Nigeria, who has been training all around the world, and he's come to Ghurki for 6 weeks with the AO fellowship. So he's also going to talk in this webinar and give it an international character. So without further ado, I hand it over to the young stalwarts, Pasha, Rizwan, and Farooq. And my only regret is that because of some commitments, Dr. Atiq Durrani is not going to talk in this webinar, but hopefully, inshallah, he will participate in the future webinars, hands-on courses, etc. So good luck, and Bismillahir Rahmanir Rahim. Time to kick off. Thank you.
Thank you, sir. Thank you very much for your remarks. Now I will start with my own presentation. So can everybody listen? Is hearing me? Okay. Bismillahirrahmanirrahim. The topic of my talk is epidemiology, risk factors, pathogenesis, and natural history of prolapsed lumbar intervertebral disease. If you go through the history, the Hippocrates were first to describe the sciatica, but they thought that it was the intake of wrong fluid mixture. But Catagno in 1764 described the nervous origin of this problem, and Maxton and Barr in 1934 established the link between disc and sciatica. If you see epidemiology, the annual incidence of sciatica is about 5 to 10%. Women and men are at equal risk. There is increased incidence with age, mostly environmental factors. They are thought to be the cause of prolapsed intervertebral disc. Dissectomy is still the most frequent performed spinal surgery, and dissectomy rates exhibit strong geographic variations. If we see incidence and prevalence, the incidence of prolapsed intervertebral disc causing sciatica, the lifetime incidence is about 40 to 35%, and this is above the age of 35 years. But if we see the incidence about 5% below the age of 35%, the lifetime incidence is about 13 to 40% in different geographic distribution, and the annual incidence is 1 to 5%. Age distribution, it is rare before the age of 20. The peak incidence is 5th decade, and there is similar age distribution in surgical cases, and odd ratio of sciatica increased by 1.4 per 10 years of age up to the age of 64 years. If we see level and location, L5S1 is most commonly involved, then L4-5, and then the upper lumbar level, which increases with the age. The lateral disc prolapse is more common as the central ones, and the extrusion is more common than protrusion in the operated cases. Central disc herniation and protrusions have similar results when they are operated upon. The epidemiology of cauda equina and conus medullaris is less well understood, but some investigator showed annual incidence is about 3.5 to 1.5 per million, and period prevalence, that is number of patients present at one time, is about 8.9 per 100,000. Cauda equina can also result after surgery of the spine in this region, and its incidence in different study is 0 to 0.6%, and it is more in older patients. But it is also surgery related and technique related thing also, because there is one study in which probably some untrained surgeon have caused 11 cauda equina iatrogenic injury in about 70%, which is quite high ratio as compared to the rest of the world literature. If you see the association of prolapsed intervertebral disc, there are mixed sort of pictures. Some studies have shown that gender differences, weight and height, but the most study shows that there is some association of cigarette smoking and other things. A previous trauma is also associated with disc herniation. After disc herniation, its symptoms, they are more related to physical and mental stress and job satisfaction. Goldberg, in their studies of about 38 studies, showed that cigarette smoking was the cause of prolapse intervertebral disc or one of the associations. And another author showed association with smoking, mental stress, and walking with the prolapse intervertebral disc, especially once it is prolapsed, walking has got a negative effect on the prolapse, and jogging shouldn't be done after the disc has been prolapsed and it is not treated. Another author showed that there is positive relationship of height and driving and vibration sort of thing. Many other authors also have shown some overweight, smoking, and decreased muscle mass or layer activities in especially in women in association with prolapsed intervertebral disc. As already told, that weight has got some association with prolapsed intervertebral disc by some author, but there is more effect of this cause on recurrence of the disc, and the authors have shown that recurrence of disc is more common in obesity than the lean persons. Genetic factors are also associated in prolapse of intervertebral disc. But the occupational factors, they have shown more association with prolapse intervertebral disc, especially the movements which are involved in vibration, forward bending, twisting, and lifting heavy weights. These association were studies, and different risk factors were evaluated by different authors, and they showed that prolapse intervertebral disc has got more association with frequent heavy lifting, twisting and bending, exposure to vibration, and sedentary activities and driving. Cook in 2014 reviews different articles and come up with incidence of these risk factors in about 1 to 37% of the cases, and he divided into modifiable and unmodifiable risk factors. Modifiable risk factors are smoking, obesity, occupational factors, and health status of the patient, and unmodifiable are age, gender, and social status. Age-related changes of spine degeneration, as we know that the spine column degenerates far earlier than other musculoskeletal tissues. Age-related changes of the spines are not synonymous with the painful alterations. Time course and probability of early degenerations are largely determined by genetic disposition. Intervertebral disc is largest avascular structure in the human body, resulting in large diffusion distances to allow the disc nutrition. Compromised disc nutrition is key factor in disc degeneration. Changes in the matrix components of the intervertebral disc, especially the proteoglycans, determine age-related changes of the disc. But how this disc degeneration due to these factors, that is pathogenesis, the theories are both mechanical compression and chemical irritation leading to radiculopathy. Nerve compromise is not necessarily painful. Nerve compression is not necessarily painful. It is the chemical irritation due to compression or isolated chemical irritation that has got decisive role in sciatica. TNF alpha plays a dominant role in the generation of sciatica. Mechanical compression theory is that due to mechanical compression, there is alteration in the blood supply, and which ultimately leads irritation of the nerve and causing pain. Because if you do a mechanical compression or even cut the nerve, there is very little pain. But chemical irritation over the compression causes pain. Epidural application of autologous nucleus pulposus without mechanical compression induces sciatica. That has been investigated by different authors, and they have found different chemical like hydrogen, nitro oxide, phospholipids, tumor necrosis factor alpha, interleukin 1 and 6 to be the causative irritants in these cases. And an antagonist or inhibitor of TNF alpha can be used and has been used in experimental studies for alleviating pain, but the results, they are not consistent, probably because TNF alpha is not the only irritant, and there are many other irritants like hydrogen nitroxide and etc. Immunological reaction is due to that one should appreciate that nucleus pulposus is the center of the disc, and it is not come into the immune system of the body because it has been surrounded by the annulus fibrosis and end plates on both sides. So once the nucleus pulposus or its contents come into the canal, the body assumes that it is alien and irritant because this has never come across or recognized by the immunologic system of the body. So there is intense sort of immune reaction and pain. Different authors have confirmed this by higher level of nuclear fibrillary protein levels in the CSF after disc prolapse. And even the raised antibodies to these different irritants has been detected in many cases of the sciatica, and this test has been tried in different experimental studies, but no commercial test has been available against these detecting these antibodies and diagnosing the sciatica cases. If we go to the natural history of the lumbar disc diseases, the lifetime incidence of backache is about 80%, and the life incidence of prolapsed intervertebral disc is about half, that is about 40%. And natural history is resolving. The 70% showed marked improvement, 60% returned to its work within 4 weeks. But at 1 year, 32% of the patient had got some problem. Since the lumbar disc herniation has favorable natural history, many of the authors, they don't recommend any specialized investigation for within first 6 weeks if there is no red flags, which are of course the cauda equina or severe weakness. If there is only pain for first weeks, most of the author recommends conservative treatment, because the authors have shown that in serial MRI that there is reduction in the size of prolapsed disc over a period of time, and large exclusion disc shrink rates. It means that if you have got one extrusion or protrusion, there are chances that it will resolve after 6 months MRI or 1 year MRI after that time. And these has been proven in different MRI serial studies that 76% extrusion resolved within 1 year, and 82% bulging discs they may unresolved after 1 year. It means that more the disc is, there are better chances that it will resolve over a period of time. And migrating disc resolves more than protrusions. MRI changes are also seen in asymptomatic patients. This is one study in 2015 in about 3,000 cases, which showed very high incidence of disc degeneration and protrusions in normal population. And this also shows the increase in incidence with the aging. But what is less common is disc extrusions and the spondylolisthesis and facet degenerations. These are more pathological as compared to disc bulge and protrusions. MRI changes in asymptomatic discs were also studied in by Bose in 46 surgical cases with 46 risk-matched cases, and they showed that risk-matched persons with same weights, with same height, and other job-like things, they had got more association than the normal population. Prognostic factors in non-surgical cases, they are mainly there is no association with age, body mass, smoking, or sensitive diseases, but the association were of leg pain with subsequent injury. Means that if the patient has got more leg pain, he will probably go into the surgery than with the other associations. If you see, the surgery, discectomy is the most frequently spinal surgery performed, and men, they are more operated than the women. But there is a lot of reoperation rates. There is about 7% reoperation rate at 1 year and 9% reoperation rate at 2 years. And different studies shows that about 7 to 17 or 18% reoperation rate within 5 years down the line. These are different sort of registries, like Tango Spine Registry, and this is the Swedish Spine Registries, which shows two important things. One is that the trend of discectomy is decreasing from 50% to 33% from 1997 to 2003, and then in 2005, only to 28%. It showed that trend in the discectomy is decreasing, as we know that this the natural history is more benign. And if you see the complication of this surgery, there is about 5% intraoperative complication. Most of them, they are dural tears. Surgery has got geographic distribution. Some countries, they are doing more discectomies than the others, and the US is leading in the world. Probably the indication of surgery, they are not standardized. Indication of surgery, absolute, they are quad iguana syndrome, severe paresis, and paresis in the thoracic disc. Same, the disc surgery rate in different part of the world. This is the one of the leading surgeon, Alf Nakemsons. He proposed that surgery in the disc problem should be done cautiously, because most of the studies, they show about 65 to 80% good results, which is about same or even 10% less than the natural history of disease. And also, if you do surgery for discectomy, all the surgeries, different types, micro dissectomy, endoscopic discectomy, and the other laminotomy, laminectomy, all shows good to excellent results. This has been shown by Dorman in about 40,000 cases taken from the literature. In summary, I must summarize that the lumbar disc herniation is a common condition, and often it is asymptomatic. Etiology is multifactorial, mechanical, nutrition, and genetic factor. Pathogenesis of sciatica is nerve compression, chemical irritation, and immunological reaction. But one should note that 70% they resolve in 1 year. The bigger the disc is and extruded, it is resolved better than the smaller ones. And there is wide variation in the surgery for the obvious reason. Thanks for your patience listening. Thank you. We will have answer and question at the end of the session. Please note your question in the chat box on the side, and I will try to answer all the question, or as many as question. Now I request Dr. Farooq Bashir for his talk on diagnostic workup. जी हाँ। और वो आपका क्यों नहीं हो रहा? आपकी वीडियो तो आ रही है, रुकिए जरा। देखिए मैं आपको आस्क टू, ये आपकी वीडियो आ रही है। देखिए मैं आपको आस्क टू अनम्यूट कर रहा हूँ, अब देखिए क्या हो रहा है।
जी। Now you allow me to start my screen sharing.
ओके। अब आपकी ये मजे आपसे स्क्रीन करें।
Host disabled participant screen sharing. You should allow me, sir, to start my screen sharing.
आप बिना करें शेयर।
Still not, sir. Nabil,
आप दोबारा शेयर करें जरा आप स्क्रीन।
शेयर हो रही है सर?
हाँ हो गई है, हो गई है। ओके आप करें, कंटिन्यू।
Now you can see, please, and listen me.
जी जी हाँ, जी प्लीज फरूक कैरी ऑन।
Bismillahirrahmanirrahim. My responsibility is to tell you about the diagnostic workup for the lumbar disc disease. I am Dr. Muhammad Farooq Bashir. I am Associate Professor at Orthopaedic and Spine Surgery Unit in Ghurki Trust Teaching Hospital, Lahore. I will discuss about a little bit about introduction, as Dr. Ibrahim Farooq Pasha detailedly described the introduction and anatomy of the lumbar disc degeneration, but I will briefly describe the introduction, anatomy, pathophysiology. Definitely they are important for the diagnosis and the types, clinical presentation, examination, and the diagnostic workup to establish a proper diagnosis to execute the treatment. Lumbar spine is 25% of the total height of the spinal column. The disc is made up of two things. As you all know, it is annulus fibrosis that is made up of type 1 collagen, and nucleus pulposus that is made up of type 2 collagen, that is sulfur inside. It contains highly polysaccharides content, and 88% is the water. And when there is aging, there is dehydration of the disc, and it converts into the fibrocartilage. In diagnosis and the treatment of patient with back pain, everyone should consider degenerative disc disease in its higher probabilities. And in addition to patient history examination, the patient response to the non-operative conservative treatment, there should be various diagnostic studies for the diagnosis of the degenerative disc disease, and there are also exclusions of other diagnoses. Regarding the anatomy of the spine, as you know, there is two-column theory of posterior column and the anterior column. The posterior column is made up of ligaments, spinous processes, foramens, and the anterior column is made up of anterior longitudinal ligament and the posterior longitudinal ligament, and the disc and the vertebral bodies. Regarding the pathophysiology of the disc degeneration, a herniated disc may occur due to the gradual degeneration of the disc and from the injury, slip, fall, repetitive activities, turning, vibration, and different risk factors, as it is detailedly described by the Professor Ibrahim Farooq Pasha. This is very important slide regarding the disc degeneration related to the aging. With the aging, there is the degeneration of the hydrophilic proteoglycans in the nucleus pulposus. That leads to the dehydration of the nucleus pulposus and loss of water, and it causes decrease its shock absorbing capacity. And then later on, there is mechanical loading compressions leads to tears in the annulus fibrosis. This tears in annulus fibrosis causes the nucleus pulposus to extrude through these tears and lead to the disc herniation and rupture. The nucleus pulposus, if it pushes out laterally in the foramen, it causes lateral disc herniation. And if it is pushing the posterior longitudinal ligament in the center, it causes central disc herniation. Definitely in lateral disc herniation, there are two symptoms. It's radiculopathy or the cauda equina syndrome. Whether it's central disc herniation, it causes spondylosis or myelopathy. As you can see in the picture, in the axial and sagittal view, there is the tear. Here, there is the tear in the annulus fibrosis, and it causes the nucleus pulposus, that is green in color, to come out of its place and compressing the nerve root. To understand the pathology and to execute a treatment, you need to know these are the stages, type, whatever you say, of the disc degeneration. First of all, there would be a little tear in its early stages in the annulus fibrosis, and the inside nucleus pulposus pushes it outward in the canal, and it is disc protrusion. In the second stage, when there is no resistance from the annulus fibrosis and nucleus pulposus just causes pushing, it causes prolapse, second stage. And at last, the annulus fibers burst out and the nucleus pulposus tries to come out of that boundaries, that is disc extrusion. And when the part of nucleus fibrosis cuts from its original and comes in the canal, it is the sequestrated disc. When we have to establish a diagnosis, the most important figure is the history. Patient usually present with the low back pain. It might be with or without history of trauma. There is radiculopathy often if there is a lateral disc or paracentral. Pain may be worse while walking. There might be leg numbness, motor weakness, bowel or bladder dysfunction. There might be groin numbness if it is increased in size and compression is significant, and there might be paresthesias. According to the radiculopathy workup group of North American Spine Society evidence-based guidelines, development committee recommended manual muscle testing, sensory testing, and spine straight leg raising test is a gold standard for the clinical diagnosis of lumbar disc herniation. Other tests might be the hypertension test, cuff reflex, femoral nerve stress test, the absence of the reflexes, but the meta-analysis concluded that the sensory tests, muscle tests, and the straight leg tests are sufficient to establish the clinical diagnosis. On examination, the motor findings are typically normal, but with the prolonged disease, there might be weakness of the area involved. Sensory, there are dermatomal patterns for the disc herniation, and the reflexes are usually normal, but there might be hyperreflexia at the involved nerve root. One of the gold standard is the straight spine leg test, and if it is with the knee extended and leg is raised and there is exacerbation of the pain from 30 to 70 degree, it is quite sensitive for L4, 5, and S1. Cross straight leg test is if the raising of the contralateral leg with the knee straight causes the pain, it is significant for the disc prolapse. Femoral nerve test is done with the patient in prone position and the hip is extended. The examiner passively flex the knee and the sign is present if the movement exacerbate the symptoms. It is more sensitive for L2, 3, and 4 nerve roots, but not specific. These are the different dermatomes. You all know what are the movements for related, like hip flexion is with L2 and 3, extension L4 and 5 I will focus on the knee flexion, that is for L5S1. Ankle dorsiflexion is L45. Great toe extension for L5, and ankle plantar flexion is with S1 and S2. This is very important slide. Level of lumbar disc herniation. The nerve root, if it is L3-4 disc prolapse, the nerve root compressed is L4, and the reflex that might be diminished is the knee reflex. The motor weakness would be the knee extension, and the sensory distribution is the medial malleolus and the medial foot, and the pain distribution would be in the anterior thigh. If the disc prolapse is at L4-5 level, the nerve root usually is involved is L5, and the reflex that is diminished is medial hamstring. The area of motor weakness would be the foot dorsiflexion resulting in foot drop, and sensory distribution would be toe and the dorsum of the foot, and the pain distribution is dorsolateral thigh and the calf. If the nerve disc prolapse is at L5S1 and the compressed root is S1, the reflex that would be diminished, it would be the Achilles reflex, and the motor weakness would be the plantar flexion. Sensory distribution is the lateral malleolus and the lateral foot, and the pain distribution would be the posterior thigh of the calf muscles. Regarding the imaging, after history and examination, there are standard investigations like plain radiograph, CT and CT myelogram, MRI with or without contrast according to the indications, and the discography. The radiograph, the standard radiographs are standing AP and lateral views, and the for the instabilities and different other things, there should be flexion and extension views. They are to rule out some spondylolisthesis, fractures, gross instabilities, scoliosis, muscle spasms. As you can see in this X-rays, if you can see there is decreased in the disc space at L5 and S1, and it is a normal lateral X-rays, and the other disc spaces are equally good, but the L5 S1, the nerve disc space is quite decreased. This makes a diagnosis of degeneration at that level. If we get the flexion and the extension views, and we can see the disc space in both extension and the flexion views, there is not gross instability at that level, and sometimes the upper level is also involved, so we have to check the upper levels. There is no gross instability in both the involved and upper levels. If we compare with this X-rays, you can see there is there bit listhesis at the level of L4-5, and there is opening of the space as the flexion and comparison of the flexion and the extension views. CT scan in degeneration disc disease itself is a limited value to make a diagnosis of degenerative disc disease, but it is helpful to exclude other diagnoses and to check the other diseases involving this cascade of degenerative disc disease, including spondylolisthesis, pars defect, and other things. As you can see, there is the listhesis at the level of L4-5, and you can see the level, the pars defect at the same level. That leads to the degeneration. The gold standard for the degenerative disc disease is again MRI. It causes soft tissue like nucleus pulposus, annulus fibrosis, nerve root, ligamentous, everything it can describe, and it is sufficient to make the diagnosis, the MRI. Indication to get an MRI is if a patient had 4 to 6 weeks of leg pains, 3 to 6 months of low back pain that is severe enough not relieving with the medication, and if the patient may have lumbar spinal stenosis considering epidural injection and the pain is still there. An MRI is important in degenerative disc disease, and usually T2 weighted images are more important in MRI, and it shows the hydration of the disc and the annulus fibrosis and the nucleus pulposus. Decreased hydration leads to the loss of signal intensity on the T2 images, which leads to the darkening of the disc in the image. As you can see, if we read this MRI, there is quite, you can significantly in the upper level, you can see that white nucleus pulposus, the T2, and the annulus fibrosis at the all upper levels is quite differentiable. We can see both of those things in the MRI, they are different, annulus fibrosis and we go down at the L5S1 level, you can see there is dehydration of the nucleus pulposus at L5S1. Along with this, there is a little tear in the annulus fibrosis, and it is white in the T2 image, and a part of nucleus pulposus or it tears show, this bulge is called due to tears and the protrusions at the L5S1 level. From the posterior, we can see there is a mild hypertrophy of the ligament, posterior ligament at this level. And similarly, if we see in this cut section, there is dehydration at the same level in the disc, and there is a little bulge on the lateral side, and there is a hypertrophy all the way from the posterior ligament. In this picture, you see completely dehydrated L5S1 disc. And this is the black disc, and this is the degeneration. But unfortunately, the posterior ligaments look normal, and you can compare it with the upper levels. This is for the comparison. These are the grades of degenerative disc disease. As you can see, at grade 1, at this disc level, if you see, there is homogeneous. Nucleus pulposus and annulus fibrosis, they are clear. They are not mixed. They are different. This is white is annulus fibrosis, and inside is the nucleus pulposus. In grade 2, you can see there is also inhomogeneous with horizontal bands inside. Horizontal band inside. In grade 3, inhomogeneous. You can differentiate, but they are just mixing each other. In grade 4, you cannot, the distinction between nucleus pulposus and annulus fibrosis is gone. It is the grade 4, and in grade 5, there is hyper-intense. They are now with the degeneration and the decrease in the height also. Regarding the modic changes of the vertebral bodies and the adjacent to the disc degenerated, in modic 1 changes, there is decrease in T1 weighted images and increased signals at T2 weighted images. These changes are infrequently associated with the back pain. You can see there is disruption and fissuring of the end plates. In type 2 modic changes, in T1 image, their signals are increased, and T2 they are neutral. There is yellow marrow replacement at the adjacent vertebral bodies and end plates. And in modic type 3 changes, that there are decreased signals both in T1 and T2 weighted images, and these changes are due to the bony sclerosis at the end plates. Discography is controversial studies not performed regularly in our setup or even a lot of setups in the world. It is designed to pre-operatively correlate with the MRI findings. It needs a needle to be placed inside the intervertebral disc and dye is injected, and the pain is elicited with the concordant pain, and studies can be performed at multiple levels. Evidence suggests that annular tears by the needle during discography may accelerate the rate of symptomatic disc degeneration. It is not continued no more. You can see in the, it can be done with the X-rays and even with the CT, the discograms done at various levels. There are different various recent advances that are in process now. That is T1 MRI, chemic. This one is to see the different stages of the disc degeneration. Chemical exchange, saturation, transfer MRI. As you can see, these are for the radiological and to see the cascade, where is the stage of the disc degeneration. Ultra short time to echo MRI to compare both two pictures. Sodium MRI, and there are pain genes to elicit the pains and check their levels in the body to see what type of degeneration and what stage causing the pain. There is an artificial intelligence is a new diagnostic perspective In it, there is a disc localization, segmentation, analysis of the intensity, shape, and other features of intervertebral disc in the spine. MRI are usually done by the radiologist with the subject and time-consuming assessment that depends upon individual experience and knowledge. So concluding my diagnostic work, a good examination, a dermatomic and myotomic assessment of the patient, three things: clinical assessment with the history, state leg test, dermatomic, and the myotomic examination usually establish. And to augment your established diagnosis, you need to have an MRI and good reading of the MRI, and you are now supposed to treat the patient according to the stage of the disease. Thank you very much, everyone.
Thank you very much, Dr. Farooq, for your nice talk. Can you please unshare your screen? Dr. Farooq, you will unshare your screen from the green box. Where you had click for share the screen on the same spot.
Just a minute, sir.
Okay, meanwhile, I will just request Dr. Sir Amjad Iqbal, General Amjad Iqbal, are you there? अस्सलाम वालेकुम
जी
सर, क्या हाल है?
जी वालेकुम अस्सलाम पाशा, मैं ठीक हूँ, आप कैसे हैं? आवाज आ रही मेरी?
जी अल्लाह का शुक्र, ठीक ठाक. So the next talk is with General Amjad Iqbal. He is a pain specialist, and he is pioneer and in this specialty in Pakistan Army, and he is a supervisor of anesthesia and pain specialty. Over to Sir Amjad Iqbal.
Assalamu alaikum everyone. Can you hear me?
जी सर, मैं आवाज आ रही है.
चलो मैं थोड़ा स्क्रीन शेयर कर लूं, फिर उसके बाद स्क्रीन भी आ रही है?
जी सर, स्क्रीन भी आ रही है.
चलो ओके. Thank you very much, Dr. Ibrahim Farooq Pasha. I'm really grateful and highly obliged to the Pakistan Society of Spine Surgery and President Dr. Amar Aziz and Dr. Ibrahim Farooq Pasha for giving me an opportunity to interact with my colleagues from other specialties to talk about a very important subject of low back pain with radiculopathy. As you know, Pasha, we are managing and running these pain clinics and pain centers for the last 30 years in different hospitals of Pakistan Army. Now there is an outburst of these pain centers all over the country now. But we have observed and seen that in our OPD, 40 to 50% of patients reporting to our pain clinic or pain center of low back pain with radiculopathy. Out of this 40 to 50% patient, about 5 to 6% of the patients are those which come to us with a failed back surgery syndrome. So before I start my discussion on the subject, let me forward it. The topic you have given me to talk about the non-surgical treatment option for disc herniation. These treatment, the rest physical therapy, this heat and cold therapy, this medication, the anti-inflammatory drugs, anti-convulsant drugs, and this manipulation and traction, they provide relief, good relief up to the 20 to 25% of the patient. Whereas about 80% of the patient, they still suffer with the pain. So today, the main topic of my discussion would be the role of epidural steroid injection in lumbar disc herniation. Epidural steroid injections they are not just an injections. They are procedures. They are interventions. They should be performed at a place where all resuscitation and monitoring facilities are available. They should be performed under an entirely sterilized environment. So before we undertake this intervention or procedure, I think exact diagnosis of the patient should be confirmed before giving these injections to our patients. Otherwise, failure rate would be very, very high. Here, I would like to just quote a study, just augmenting a study you presented. This is an older study, but still very relevant. These MRI were carried out on 98 asymptomatic patients over the age of 50. The results were as listed: 52% had disc bulges, 27 had disc protrusion, 1 had disc protrusion, 14% had annular defects, 8 had this facial pathology, 7 had this spondylolisthesis, 7 had this stenosis. When these MRIs were sent to the world-renowned, not in Pakistan, the world-renowned spinal surgeons and these neurosurgeons, without patient data, you will be surprised to know that 60% of the consultant, they recommended surgery on these patients, whereas all these patients were asymptomatic. The point which I want to emphasize is that this MRI alone, the MRI changes should not be the basis of any intervention or to talk of surgery. Even we should not give these epidural injection in such patient on the basis of MRI. So clinical examination history and clinical examination, it is the very, very important part. So you have to be very specific about the diagnosis when you administer any treatment. So again, I just highlighted these few conditions before I come to my topic of this lumbar steroid epidural injections. These conditions are not very uncommon. In our clinical practice, especially patients who are coming to our clinic with a failed back surgery syndrome, when we carefully examine them and we find other causes as well, which has been probably ignored at the time of intervention. So sacroiliac pathology, but I'm not going into the detail of these conditions. Just I'll be showing this pattern of pain, pattern of the radicular pain. This comes with these conditions. It's some estimate that the sacroiliac pathology constitutes about 90% of low back pain. You can see the radiation of the pain. In our clinical practice, we see that patient coming with excruciating severe pain, pain going down the leg up to the ankle, even going into the foot without any radicular distribution. In most of the cases, the pathology is in the SI joint, where in this condition, epidural injection would be a complete failure or disaster. They are of no help. Otherwise, failure of epidural injection, it creates disappointment in the patient as well as in the doctor's mind as well. There's a next very important pathology, and again very common, that is facet. Classically, it is said that this facet pain goes up to the knee, but we have seen that facet joint pain can go up to the ankle, especially when the hypertrophied facet joints, some osteophytes is protruding into the canal, just going through this ligamentum flavum, irritating the nerve. The pain can go up to the leg, into the foot as well. Preformer syndrome, again, the nerves are trapped in the preformous muscles. So there's no use of giving epidural injection in such patient. Again, it would be a failure. Clunian neuralgia, usually this we know that this medial branch of the posterior ramus, they supply the facial joint, but lateral branches, they fall on the iliac crest, and sometimes these nerves are trapped and they cause low back pain, and this pain can also go referred to the foot as well. Superior gluteal neuralgia, these nerves come out in between the preformis muscle and this medial gluteal muscle. That the nerve is trapped in between those two muscles, and pain can also go into the leg as well. Again, ischial bursa, you can see the pattern of pain. This is a greater trochanteric bursitis pain. I think it's a badly ignored and overlooked part. Now you see the radicular pattern. So you can see the problem here is that when you see this MRI, you see a disc changes. And then you ask the patient, so aapki dard kis jagah pe hai? Patient would say that my pain is going down the leg up to my foot. So immediately you either, if you are a surgeon, you start planning this surgery. If I am a pain specialist, I'll immediately start planning these epidural interventions. So we have to exclude these non-discogenic radicular causes as well before administrating any intervention. Iliolumbar ligaments, again, accidentally it can be ruptured, or during fusion surgery, these ligaments can be damaged. Their pain can also radiate down to the leg. These are sacrotuberous and sacrospinous ligament, again very common. Again very common. I've seen so many patients when they were not responded to epidural, then after careful examination we found they have the sacrotuberous sacrospinatus ligament damage. Now we come to this lumbar steroid epidural injection. The main goal of this epidural steroid injection is to manage pain and the associated symptom caused by the irritation and inflammation of the spinal nerve root in lower back due to certain conditions. This, as we know, the steroid injection is used for this lumbar radicular pain, and this pain may be accompanied with numbness, tingling, paresthesia, at times dysesthesia, and sometimes they are associated with burning and muscle weakness in the distribution of affected nerve. The epidural space, we know that this space surrounds the spinal cord like a sleeve. It contains, this space contains fat, spinal nerves, blood vessels, and connective tissue. This space has a lot of capacity. Drug can easily be administered and placed in this space, and they have an effect on the exiting nerve roots. The medicine which we administer is a combination of local anesthesia, normal lines, and steroid. There are two types of steroids. There are particular steroids and non-particular steroids. Particular steroids are dapomedrol and triamcinolone, and the non-particular is dexamethasone. Dexamethasone is a short-acting, relatively short-acting, whereas these particular steroids, they have a long effect. These, when these injections are given into the over the nerve root, the particular of this steroid, they get attached to the inflamed nerve and produces excellent anti-inflammatory effect. Now, how does lumbar epidural work? Epidural steroid injection delivers a powerful 1 to 2 punches. But I say it delivers not 2 punches, delivers 3 punches. First, the local anesthetic quickly goes to work to dull the pain signaling coming from your affected nerve. Second, the steroid addresses the inflammation that's irritating you now. The third punch is that we are using a lot of normal saline. We are mixing these drugs in a normal saline. In my practice, I give 10 to 12 ml of normal saline in the epidural space. What does this normal saline do with these exiting nerve roots? Number one, it dilutes the this inflammatory part of this this. Second, it has it produces adenolytic effects on the side, reduces the inflammatory adherence from the nerve roots, just to produce reduces the pressure from the nerve. What we have seen immediately after this injection, patient observe a good pain relief. Patient, if he is having numbness, immediately patient say my numbness has reduced, my paresthesia has reduced, my tingling sensation has reduced. Now, condition which can cause lumbar radiculopathy. There are so many conditions which can irritate the spinal nerve. The important one I'll just mention over here. We have already discussed, and today we are discussing the same topic. This lumbar herniated disc. The second is the lumbar degenerative disc. This condition happens when the cushioning in between the vertebrae and the lumbar spine begin to wear away. A degenerated disc could cause local inflammation in spinal nerve roots. Lumbar spinal stenosis. This condition is the narrowing of one or more spaces within the lumbar spine. Less space is available for spinal nerve roots. A tightened space can cause the nerve to become irritated or pinched, which can lead to lumbar radicular pain, especially with repeated activity like walking. This lumbar osteoarthritis, lumbar spondylosis. This condition involves changes to the bones, disc, and the fascial joints in your lower back, caused by the normal wear and tear of aging. Lumbar osteoarthritis can lead to narrowing of the interior of your spinal column in your lower back, or in the opening where spinal nerve exits, which can cause inflammation and irritation to this nerve. Now, different ways to approach epithelial space. There are 3 different routes. Transforaminal approach. We go directly into the foramina where the nerve is pinched. Then this interlaminar approach and the caudal approach. The transforaminal approach requires a very precision of the placement of the needle into the spinal canal from the side. For this approach, 22 gauge spinal needles are used, and this procedure is performed under fluoroscopic guidance. After the proper placement of the needle into the foramina over the nerve, we take AP and lateral views through the fluoroscopic guided image and confirm the position of the tip of the needle in the foramina, in the middle of the foramina. Then dye is given just to see the spread of this dye into the epithelial space as well as on the exiting nerve roots. When these conditions are observed, then we give a targeted solution, which I have mentioned, the solution of local anesthetics, steroids, and this saline. Some people are using hypertonic saline as well, just to reduce the adherence already present in this area. I tell you, the results are very good. 80% of our patients, they respond to this treatment, and immediate pain relief is very good with this technique. Then interlaminar approach, this is older one. The needle is placed between the lamina into the epithelial space. Here we are not using these spinal needles in this place because there are chances of dural puncture. So specialists needed Tuhi needles with blunted and curved tip. These needles are used. This epithelial space by this route can be approached by 2 ways: a central approach, median approach, or a paramedial approach. This provides good pain relief for disc herniation, spinal stenosis, with or without radicular pain. Caudal approach is very commonly being used. This provide good short-term pain relief for failed back syndromes and lumbar spinal stenosis. Have fewer risk than interlaminar and transforaminal epidural steroid injection. Easy to administer. This sacral hiatus, we all know that is present in the 4th and 5th sacral, the back of the 4th and 5th sacral vertebrae. Said that area is deficient of this spinous process and the lamina. There is a hiatus. We can pass a simple 21 gauge 1.5 inch needle into this space, and this procedure can also be done under fluoroscopic guidance as well as under ultrasound. Then medicine can easily be given. But do remember, don't take it so easy. A complication can happen with this technique as well, because we all know that this CSF finishes at the level of S1 or S2. So if you push the needle little more, it can enter into the CSF and can cause a total spine. The side effects of epidural injection are very rare. Patient may have tenderness or bruising at the site of injection. If fluoroscopy is used for image guiding, there will be a minimum or low level radiation exposure due to the access. Fluoroscopic access may be harmful to unborn babies. It should be avoided in pregnant ladies or the ladies who want to be pregnant. It should be avoided, and proper consent should be taken before undertaking this procedure. In diabetic patient, we have seen there's a slight rise in blood sugar level. This could last for hours or even days. We ask our patient just to increase the dose of their routine this anti-glycemic drug. If they are insulin, they can increase 1 to 2 units of insulin just to counter this effect. In hypertensive and glaucoma patient, ESI may temporarily increase blood pressure and the eye pressure. So patient should be informed about these things. Immediate pain relief is very good because of the effect of local anesthesia and normal stand. Once the effect of local anesthesia is over, some pain may come back. Best effects are seen after 2 to 7 days. Then the pain relief can last several days to a few months or even longer. The complication of lumbar ESI, again, they are very rare, but there are risk of certain side effects and complications. The BP, blood pressure can fall because of this sympathetic blockade. PD, post-dural puncture headache can occur, but this pain comes after 24 to 48 hours. This could be because of the dural puncture. Infection, we all know that can cause a problem. Epidural abscess, discitis, osteomyelitis, and meningitis can occur if these precautionary measures, sterilized measures are not observed. Hot flushes or a rash because of some drug reaction, bleeding, hematoma can occur. Damage to the nerve at the injection site. One thing I always advocate and tell my colleague as well as junior colleague that all these epidural injections should be done in an awake patient. They should not be performed in an unconscious, in an anesthetized patient. So there are chances in anesthetized patient, in unconscious patient, there are chances needle can directly enter into the spinal cord or into the nerves, and they can cause a permanent damage. There are few studies where it has been observed that the procedure was done under general anesthesia, and this dye was directly injected into the spinal cord, and later on patient had this paralysis. Temporary loss of bladder control can be observed, but though it is very rare. Long-term side effects are again very rare. Receiving an epidural steroid injection can lead to some long-term complication, including permanent neurological damage due to spinal cord or nerve root damage from injection, as I have already mentioned. These procedures should not be done under sedation or under this general anesthesia. Chronic pain can happen due to spinal cord or nerve root damage from injection. Permanent paralysis from an epidural hematoma abscess can occur, though it's very rare. Now, what is the prognosis of lumbar epidural steroid? It is impossible to say how long your result may last after an epidural steroid injection. As some patients report weeks of pain relief, while others enjoy years of freedom from pain. Whatever the time frame, it is important that you use this reprieve from your pain to take important step towards avoiding pain in the future. At the top of this list is the physical therapy. Muscle strengthening exercises should be started so that the spinal support can be strengthened. So how long do ESI last for lumbar radicular pain? Studies on lumbar epidural steroid have revealed that they can provide reliable pain relief for up to 6 months in many cases. As Dr. Pasha has mentioned in his presentation, that most of these they reduces by themselves after a year or two. So if we can give a good relief, pain relief or symptom relief to these patients, say for 6 months to 1 year, so by the time this will be automatically reduced, and patient will have a long-term effect. Lumbar epidural steroids are more successful at providing good pain relief for radicular pain caused by a lumbar herniated disc and lumbar spinal stenosis. One study revealed that for people with radicular pain secondary to disc herniation who received a lumbar epidural steroid injection, up to 70% of them felt at least 50% better at 1 to 2 months, and 40% of them felt better at 12 months. Thank you very much for patient listening.
Thank you, Sir Amjad Iqbal, for your very elaborative presentation. The question and answer, I have requested that everybody should write in the chat box, and if there is question, we will ask. Thank you once again.
Thank you very much, Dr. Pasha.
Sir, can you unshare your screen now?
Yes, I have unshared it.
The next talk is by Professor Anayatullah. He's a neurosurgeon, and he will talk about the lumbar micro dissectomy for prolapsed intervertebral disc. Professor Anayat, are you listening me? Professor Anayat, can you unmute your okay.
Assalamu alaikum.
Yes, we are listening you now.
Yes, yes. Thank you. Should I start now?
Yes, please. Please, sir.
Okay. Assalamu alaikum, my dear colleague and junior. Today, my topic is lumbar micro discectomy. Next. As we know, a discectomy is a surgical removal of abnormal disc material that presses on a nerve root or the spinal cord. Next. This slide shows how we do it. This is using a microscope. We take away the muscle from the spinous process and lamina. Suppose if I am performing at L4 file, so the lamina will be L4. So I will take the muscle off the lamina as far as the facet joint. So it's called micro decompression because it's a minimal invasive surgical procedure performed on patient with a herniated lumbar disc. That in this procedure, I call it micro because normally under the microscope, our incision is usually about 2 centimeters. Next. The indication for performing lumbar micro discectomy, as we all know, is when there is significant pain, severe excruciating pain, or there is weakness in one of the dermatome, foot drop or something like that, or there is numbness which is causing severe debility or loss of strength in your leg, or cardiac venous syndrome, pain, numbness in the genital area.
I think your slides there is not on slideshow because we are seeing only the first of your slide. Can you see this? We are still on your first slide.
Can you just see this one?
No.
New share.
I am seeing your only micro dissectomy, your first slide. It is not, you are not changing your slide. Can you sort out this problem? Yes. So can you share screen again? Share screen and then.
Can you see now the new slide?
Yes. Now this is the new one. Thank you. Please carry on.
So indication include when there is severe excruciating pain down the leg, or there is weakness or numbness in the leg or foot, or there is numbness in the genital area. Can you see the new slide? Hello? Or there is cardiac Equina syndrome, I mean, a loss of bladder or bowel dysfunction. About 10% of patients with a herniated disc or degenerative disc disease should be considered for a micro discectomy only when conservative management fail. Next slide. Advantages of micro discectomy include minimal tissue trauma and blood loss, minimal post-operative pain, and it also minimizes the hospital stay. And as far as our result, it lead to a very. This is the way how we perform. We perform it in kneel posture. We mark before we start. We mark the level with C-arm, clean and wrap, and normally we take away the muscle from the lamina and as far as the facet joint. This is just how we mark the level. Next. We don't take away the wall of the lamina on one side. We just make a small hole just to create a space. This is called fenestration, in which we take a small part of the upper lamina and medial part of the facet joint at that level. So as to create the space and for better visualization and instrumentation. Usually taking a microscope, under the vision of microscope, we identify the ligament flavum, and we take away the ligament flavum, identify the nerve root, and then under the nerve root, we visualize the disc, and usually which lead us to micro discectomy. Next. This is the disc material after taking the disc out. We only remove, our aim is to do as much as take out the disc just to decompress the nerve root. We don't take away all the disc material. Apart from it, then at the end of the procedure, we take a blunt hook and push the nerve root and check under the nerve root and in the axilla whether we have left any disc fragment. So before we close, we check that there is no disc fragment left under the nerve root or in the foramen of the nerve. Wound is just routinely closed in there. The procedure, micro discectomy, takes usually from half to 1 hour, normally about half hour. I'm sorry, the slides are not that perfect, but this is was the only case where I find the opportunity to make a video. This is the way we make a 2 centimeter incision, and we take a small retractor and take away the muscle from the upper lamina and then make a small hole. This is now I'm using upcut punch to make a small hole there. After taking the small punch out, I removed the ligament flavum, and because in this case that there was a big disc fragment, so using a blunt hook, I took out a major chunk of the disc material under the vision of microscope. Directly, the vision was far better, but because there was some problem, so that's why it is not that sharp as I was seeing under the microscope. So we can see the nerve root there, and the nerve root is completely decompressed. It's just hemostasis after taking the nerve root out, and following this, we just take out this. You can see the nerve root there. but the vision under when I was seeing it, the microscope was far better than that. Just to watch the disk space. Is just to show that we stitch the lumbar fascia. Recovery, most of these patients are up and about the same day, and about 50% of our patients go the same day home. When following the treatment protocol, most of the patients are back to work in 2 weeks or less, and back to regular daily activity in about 1 month time. Overall, the success rate is in accordance with the international study is also in our cases is about 80%. They get pain relief, complete pain relief. Next. As far as the recurrence in lumbar microdiscectomy is concerned, it is about 6 to 7%. And we checked the international study, they have also about the same recurrence rate. Redo surgery in about 5 to 6%. As far as the other complications such as CSF leak is concerned, it is about in 1 to 2% of the cases. As far as the wrong surgery level, we have no case. I have done about 6,000-7,000 of lumbar discectomy, as we are using twice C-arm, first to market, and then when I am on the lamina. So we have so far haven't operated on the wrong level, but in accordance to the international study, there is a risk of 0.5 to 1%. As infection-wise, the superficial infection is about 0.5 to 1%. In international study, it is about 0.62%. Deep infection in a study is about 1%, and in international study, it is about 0.5%. Other complications include bleeding, nerve root damage, foot drop, bowel and bladder incontinence. I hardly remember any case of foot drop or bleeding in our cases. Comparing micro discectomy with open lumbar discectomy and endoscopic lumbar discectomy. So we did some research, and according to that research, open lumbar discectomy is about, the operative time is about 60 minutes. I'm also doing the same way, open lumbar, taking a headlight. My time is about 20 to 25 minutes. But according to the international papers, the time duration is 60 minutes. My micro discectomy time is about half hour, or mostly in some cases 45 minutes. And endoscopic, as the time duration is concerned, it depends on the expertise of the surgeon. I'm also performing an endoscopic lumbar discectomy. Initially, when I started, my operative time was about 1.5 hours. But as my number went up, now I take usually 45 minutes. But in an international study, it is about 70 minutes. Blood loss and open lumbar discectomy, according to international paper, it is 140 ml. In my cases, I don't think so. It is that much. It is far less. While microscopic lumbar discectomy, again, 40 ml is mentioned in international study, but in our study is far less than that. And endoscopic, again, they have say it is on the average 34 ml. Hospital stay, I don't know, our open or microscopic lumbar discectomy, usually in 99% of our cases, hospital stay is 1 day. But in this case, according to papers, it open has a duration, hospital duration of about 6 days, and the microscopic 5 days, and endoscopic 2 days. Normally, we send the patient home the same day in endoscopic lumbar discectomy, and 60-70% of our micro discectomy cases also go home the same day. Incision length in open, it is 40 millimeter. In microscopic, it is 26 millimeter. In our cases, our incision length is about 20 millimeter. And endoscopic, it is 9 millimeter, but the instrumentation which I use for my endoscopic, it is 1.8 centimeter. Conclusion: all the three treatment modality or effective treatment for removal of disc material. Considering the bleeding tendency and adequate indication, microscopic discectomy is better than open discectomy. We choose usually a satisfactory quality of life can be achieved at 6 months after surgery. Compare with microscopic lumbar discectomy, endoscopic lumbar discectomy is appropriate for lumbar disc herniation, which is lateral. For midline lumbar disc herniation, it is a bit difficult, and also the results are not that good. But microscopic, with microscopy, it doesn't matter whether it is midline or lateral. Thank you very much. These are the references.
Thank you, Professor Anayat, for a very elaborative talk on the gold standard procedure for the disc surgery. Because as we know that microdissectomy is the gold standard operation for prolapsed prolapsed disc, and on which all the other procedures should be measured as far as the outcome is concerned. Now I request Professor Khalid Mahmood. He will talk on endoscopic dissectomy. Professor Khalid Mahmood, are you?
Bismillahirrahmanirrahim. Can you hear me?
Yes, sir. We hear you.
Well, it's indeed a great honor and pleasure for me to talk on the webinar, first webinar rather arranged by the Pakistan Society of Spine Surgeons. And my talk is about the endoscopic lumbar discectomy. I think much has been talked about the types of the disc prolapse. And very important point is that the disc can be central, it can be paracentral, it can be foraminal, or it can be far lateral. And depending upon the type of the disc prolapse, you choose what type of endoscopic intervention you need to do. Now, if we talk about the evolution of a lumbar disc surgery, it used to be open either with the naked eye or with the loupes, and then came the microscope, which is considered as a gold standard. And now we have come to the endoscopic intervention. In open discectomy, the incision length varies. It can be up to 10 centimeter. You strip away the muscles. Usually, those people who do in a conventional way, they do stripping on the both sides. Because there is a more muscle work, there is a more bony work, so there is a more backache, there is a more hospital stay. In a microsurgical intervention, the incision is up till 1 inch, and there's a less muscle dissection, but you strip away the one-sided paraspinal muscles for the unilateral. If it's a central disc, or if the patient has a significant bilateral symptoms, you do the bilateral stripping and the bilateral fenestration microscopic with the same length of the incision. But compared to the open technique, the hospital stay is less, but it still can be 2 days or more, or certainly more than 1 day. And with endoscopic, you don't strip it with a muscle, you actually split the muscles. It is usually unilateral and can be done either interlaminar or the far lateral approach. And the patient can go home the same day in the evening if you operate in the morning, or the next day, and there are less chances of the backache and other problems. Now, there are two variations of endoscopic lumbar discectomy. One is the interlaminar, that is most commonly performed. And I think all the discs that are performed in this country are usually interlaminar. You can do the transforaminal approach, and this is the incision. This is the lady with the red shirt. I operated on this lady about a year back and got her pick this very small cut. I usually use 1.7 mm sheet. So that's the green color for the endoscopic discectomy. And this is a net picture of the transforaminal endoscopic discectomy, where the scar actually is about 8 mm. It's smaller than the interlaminar approach, but this is on the side, and that actually gives you more cosmetic outcome. Those people who are into the swimming pools and the ladies in the Western society, because the cut on the side is not very much noticed. Now, about the indications, when to go for interlaminar and when to go for transforaminal approach. For a central paracentral disc, you can easily do the interlaminar approach. And for foraminal or extraforaminal discs, you can do the transforaminal approach. Similarly, you can deal with the lateral recessed stenosis very easily with the interlaminar endoscopic approach. You can also deal with the lateral recess to the transforaminal. Now, the contraindications for interlaminar is extraforaminal or a foraminal disc. Similarly, if you are doing the transforaminal endoscopic approach, L5S1, which constitutes the 45 to 50% of the cases, can give you a problem because there is an iliac crest and there is the L5 transverse process. Lumbar stenosis was considered a contraindication, but now people are dealing more and more with the 30-degree endoscope and with the little tilt of the table. You can actually deal with the contralateral lateral recess and ipsilateral lateral recess. You can shave away the lamina. You can shave away the base of the spinous process. Obviously, spinal instability at the same level is in a contraindication to do intervention because you have to add a fusion with it. If there is a large median or a paramedian disc, or if there is a cardiac equina, that cannot be dealt with the transforaminal endoscopic approach, and I think interlaminar would be a good one for that. Now, key points about the surgical anatomy. When we talk about the disc, the root comes just below the pedicle, and this is the white fat signal you look on the MRI scan. This is very important to grab the concept of the disc, the exiting root that hugs the pedicle above, and the traversing root. And usually the disc prolapse, that actually affects the traversing root. The Campbell's triangle must be very well understood because that is the basis of your interlaminar approach, and that's also the basis of the transforaminal lateral endoscopic discectomy approach. Your hypotenuse is the traversing root. The base is the transverse process, and the vertical part is the medial part of the superior facet, which you drill away. The complications have been already said. I'm not going to repeat, but I think in safe hands, it's very rare to have root damage or cause cardiac equina or cause conventional complications or do the wrong level. I think you can do CSF leak. That is still the enemy of a surgeon. But the benefit of the endoscopic discectomy is that the length of incision is very small, and B, you split the muscles. So in all of my cases of endoscopic discectomy, if I get a CSF leak, I never had to get it re-exploration because you do a watertight closure of the lumbar fascia and you split the muscles, and usually there is no leak from outside if you have a dura leak. And we don't tend to actually do any stitching of the dura if you do an endoscopic discectomy because the space is very small. But if it's a microscopic discectomy, you're doing it, you have a dural tear, you have a ability to actually slightly nibble the bone more, and through the same incision, you can actually do a stitching if it's a dorsal or at the just origin of the dural tear at the region of the root. Now, I would just go into the details. We use the second generation of the EasyGo system, which I think is the best. It's from the Karl stores. And basically, it consists of sets of dilators. And you have a sheath, and then you have a telescope, and you attach the light source. You start with the dilators. There are all sizes of dilators. You start with the pen, then you put the small, bigger, and bigger dilators. And then you have a trocar. You attach telescope, and with the telescope you attach camera, and there's a light soap, and then you have a holder. That's very important, that holds the things in a proper place. Dilators are of all size, and the very important point is that actually the black is too big. I think this is too big, and I think that ruins the idea of having a small incision through the endoscope. I have never used black. I always use green sheath, and that is about the 19 mm. I have not used black as yet, but I suppose that can be used as well. Now, when you have these, you choose the sheets, then the sheets come according to the size of the patient. If it's a very slim, you can use a small one. If it's medium, and the beauty is, if it's a very obese patient, you can use the longer sheet, and with that you have a longer telescope. So actually, you have to buy all sets of telescopes and all sets of sheets, so that you can deal with all type of patients, whether they are obese or whether they are slim or whether they are the medium size. This is the telescope. When we were operating with the Distendo system and with the type 1 generation, we had a hand clustering. And now with the type 2, it is very easy because that would not interfere with your hand movements. And we usually use the 30-degree telescope because that gives you very good angle. And very important point, that's it, that you can actually angle it. So you can do the bilateral decompression. You're using the 30-degree anyway. You can just little bit tilt it. You can little bit tilt the table, and you can drill the base of the spinous process and go to the other lateral recess of the other contralateral side. Similarly, with one endoscope, you can do the 2 levels with the same incision, slightly bigger than the usual one. If it's like 16 or 17, you can make it 2 centimeters. And you can, by tilting, you can do level above or below. But that needs a learning curve. You should have done more than 100 cases to actually start doing the contralateral decompression and start doing level above or below. Now, I think I have explained all about that. This is a type 2 second generation system. We use the HD camera at the Punjab Institute of Neurosciences. The holding arm is very important because that would actually fix your sheath so that nobody has to hold it. You can change the angles and you fix with the holding arm. And this is the insert, and this is, you can rotate it. Very important point is that once you're doing endoscopic discectomy, the buttons of your camera, they should be pointing opposite all the time, and you should be always oriented about the medial, about the lateral, about the up, forward, about the backwards, 12 o'clock, 6 o'clock, 3 o'clock, or 9 o'clock position. This is very important, and that is only possible when you keep the buttons all the time in a fixed position on the opposite side. And I think I've already spoken about that, about the benefits of the second generation. system. These are the all, so you cannot buy one sheath or one telescope. You have to buy sets of it so that you can cater to a population of different sizes. Now, steps, we have a Wilson frame always with a headrest, and that's what we use it to put the patient prone, and the abdomen is free, and we use this is my position. I'm standing and the monitor is on the other side, and on the right side you see is the C-arm. This is the C-arm, and my assistant stands on the other side and the scrub nurse stands on my side. Now, first of all, you take a Steinman pen and you mark the midline on the AP X-ray. That's very important. And next is you mark the lower end plate and upper end plate. This is very important. You mark the lower end plates and you mark the upper end plate. Sometimes there's a double shadowing and you actually have to tilt the patient table upwards or downwards just to remove the double shadowing, because that's the very, very important point. Whenever you want to work with the smallest incisions, you should be really perpendicular. I tend to go about 1 centimeter off midline, and I go right in the middle of the created disc space by marked disc space with upper and lower end plates, and you should check it on the lateral X-rays. So there should not be any angulation, because if you have an angulation right from the beginning, then your hand clutter, and then it's very difficult to get the proper view. That's how you 1.5 centimeters, sometimes one go 1.2 centimeter of the midline. And that is the ideal position of the trocar. It should be perpendicular to the lamina and with the trajectory towards the disc. And 1/3 should be over upper arch. So you should be really perpendicular to the disc and flush on. Your sheath should sit flush with the skin. It should not be protruding out, because more is the distance, the more is the difficult to work. Now, this is one of the cases of endoscopic interlaminar. We always use a 3 mm or 4 mm cutting bar, and I think it's very safe. You drill away the lower lamina. This is a 3 mm bar, so you just remove 3 mm or drill away the 3 mm of the bone. And I've never used any upcutting punches right from the beginning. And if you want to go to the contralateral side, you can actually drill the base of the spinous process and then go to the opposite side and just drill away the inner facets and do the root canal decompression on the contralateral sides. So once you have thinned out, you can always use number 1 or number 2. Usually 0 or number 1 carries a punch, because the bone is really very thin. So you can upcut it without any force. And when there is a less use of force or twisting movement, there are less chances of any dural tear or any damage, and it adds to the precision which you can do. Now you see this is the phlegm you can see, and I think the most difficult part is actually going through the hypertrophic phlegm under endoscope or microscope. If you go through it successfully, you actually retract it with a sucker, and you see under vision, and when you just see the glimpse of the dura, you put a Swedish dissector in it and go extradurally. You enlarge the cut in the phlegm, and then you start nibbling it away. Always try to work medial to lateral, never work lateral to medial, and always try working above downwards along the nerve root. If you follow these principles, there are less chances of damaging any root or damaging, giving any dural tear in it. Usually the phlegm is very thick and hypertrophied. You nibble it away. And very important point is the Karlstorffs have got a sucker with a little hook. So you can use it to retract the root and retract the theca, at the same time sucking any blood if it's there. And you do an allotomy over the display. This is the dura, which you can see very nicely. You should always try to actually decompress, because that was obstructing my vision. So I'm just slightly trimming it. And once you do more endoscopic work, you have a good depth perception. So this is the dura. This is sort of the flavum. Sorry, this is the disc space, and you are doing an anatomy with the number 11 knife. And when you do it, you take the disc out. It's very important that your procedure should be, discectomy should be accompanied by or complemented by root canal decompression, because once you reject the root, if you have done the root canal decompression, it does not give you any bad numbness or tingling or pain or root damage. And reduction is a fun if you do a little form anatomy before you do remove the disc. I think you remove as much as you can. If I enter the disc, I'm very aggressive with it. I tend to, with the curved Carrison, with the curved disc ronger, I tend to attack the central part. I do the ipsilateral part with the curved part, do the form anatomy, and that's it. So the advantage of the endoscopic disc are that the incision is very small. There is a muscle, there is no stripping away the muscle, but there is a splitting of the muscles. So that's why there is a less pain, there is early mobilization. I think in terms of cosmesis and in terms of early mobilization, early discharge, and the patient has satisfaction, endoscopic disc is better than any other procedure. Now, I think all these things have already been nicely described by Professor Anayat, one of my colleague neurosurgeons. Generally, I think there are the old studies in which the stay is very, very long. I think even when with the micro discectomy, if I'm doing it, my stay would be 1 day. If juniors are doing it, they might take 2 to 3 days, because it all depends on how much, the more tissue dissection you do, the more stripping you do, the more there's a bleeding, the more bony work you do, the more facet you destroy, the more is the pain, and the more is the stay. So if you stay very precise, usually the stay is very little, to be honest. And I had CSF leaks, but I never have to re-explore it in endoscopic discectomy. And in the microscopic discectomy, if I have a CSF leak, I make it a point to actually repair it there and then under microscope by stitching it with the 405. So the limitations are, it has a poor depth perception. Microscope is better in dealing, but since we do a lot of endoscopic work, and with the experience you get, depth perception is not a problem for you. It has a very steep learning curve, and it's very important that you must understand and you must be very ethical to deal with the pathology properly, no matter what approach you do. If you do a small cut for endoscopic or a microscopic discectomy, but you do not deal with the pathology properly, I think conventional technique is a lot better than that. I think if adequate decompression is the main aim, and if you can do it with a smaller cut, that is the bonus. You should not compromise the adequate decompression or removal of the disc by just making a small incision. Learning curve, you start off and you get confused, it's difficult, and then with the passage of time, you reach a plateau and you start enjoying. First you are confused, then it looks like a fun, and then it looks boring when it's a routine for you. There is a place for endo trainer, you can use it, but I think I would advise to the residents that they should be part of the team to assist the things. They should grab the anatomy, they should be assisting things, seeing things, and practicing on the endo trainer if it's unavailable, and then doing things under supervision. I think first 10 cases should definitely be done under supervision, and then they can sort of get on with their own. And I think the question and answer session perhaps is at the end.
So, thank you, Dr. Khalid Mahmood, for your very elaborative presentation. We will do a question and answer at the end. The next talk is with Dr. Mutalib. He's from Nigeria. He's consultant over there, and nowadays he has come to Ghurki Hospital for sharing his experience and learning further from his senior colleagues. Dr. Khalid, Professor Khalid, can you unshare your screen?
Okay. You cannot start screen.
Dr. Mutalib, just a minute. Can you unmute your mic? Dr. Mutalib, yes, now your mic is unmute. So you can start.
Okay. Can you see my slide?
Yes, we can see your slide. Please carry on.
Sorry. I'm looking for it now. Got this. Can you see me now?
Yes, we can see you now. Please start your presentation.
Good morning, distinguished colleagues from different parts of the world. My name is Mutalib Shobode. From my name and from my look, you would know that I am an adopted son of Pakistan. So I'm not originally Pakistani, and I'm proud to be an adopted son of Pakistan. This morning, I'll be talking about the complications of lumbar disc surgery. I'm presenting from the OT in Ghurki Trust Teaching Hospital in Lahore. Okay, good. These are my learning objectives. I'll be discussing the pathoanatomy and physiology of herniated disc. I'll discuss the common complications. I'll examine the literatures as well as talk about how to manage these complications with regards to the literature review. By way of introduction, and a lot has been said this morning about disc herniation. It's probably the most common cause of specific low back pain. If you're not yellow flagging or red flagging, I mean, one does not expect a 25-year-old or someone less than 30-year-old to have a low back pain. In that instance, you would do a yellow flagging or a red flagging, by which you consider either trauma, infection, or tumor. But for specific mechanical low back pain, lumbar disc herniation is probably very, very common. And together with facet arthropathy and ossification of the yellow ligament, they contribute about 98% of the cause of lumbar canal stenosis. In over 95% of cases, the disc herniation occurs in the posterolateral direction, either right or left. In our study in my hospital in Nigeria, we found that 60% of patients that had posterolateral disc herniation over a 10-year period had the disc herniation on the left. In a meager 5% of cases, and thanks to God for that, you have patients presenting with cauda equina if there is a central disc herniation through the PLL. The slide, or rather the picture on the right-hand corner, the lower side of the slide, shows an axial cut of the spine. You can see the canal in the center. So you can see the canal in the center. You can see the yellow ligament that is thickened there, as well as the disc compressing the exiting nerve root and hypertrophied facet joint. There was a study that was done and presented at the Scoliosis Research Society in 2018 in Bologna. And it was done among spine surgeons generally in the US, and it was found to be more common among spine surgeons. The reason could not be readily, ascertained at the time the study was done, but they attributed it to probably the fact that spine surgeons stand for a prolonged period of time when they are doing their surgeries. So it's understandable anyway. I couldn't lay my hand on the study as at the time I was making these, preparing these slides. The symptoms of lumbar disc herniation come about by a mixture of 3 factors. It could be mechanical, it could be chemical or biological. The direct mechanical compression of the nerve root causes pain. Second mechanism is a chemical neuritis as a result of irritation of the exiting or traversing nerve root by glycosaminoglycan and other elements that are found in the annulus fibrosus. And biologically, once there is a chemical neuritis or a mechanical compression, there is inflammation around the nerve root with a lot of fluid collection. This biological process will also cause or perpetuate the pain that the patient feels as a result of nerve compression. A lot has been said about the different types of lumbar disc herniation. It could be a protruded disc, an extruded disc, or a sequestrated or sequestered disc, as the case may be. When it is protruded, the nucleus pulposus is actually going through, but not perforating or going through the annulus fibrosus. An extruded disc goes through, but is still attached and contained within the annulus fibrosus. But when it is sequestered, it is lying free within the canal. There is also a containment classification. It is contained when it is within the annulus fibrosus and sequestered when it is lying free outside of the PLL. And the inflammatory process is mediated by cytokines. Chief amongst them is tumor necrosis factor. Epidemiologically, you find that most patients that have lumbar disc herniation are found between the ages of 30 and 50. And oftentimes you find them in the elderly as well. But in this case, most of them will present with caudal equina compression. So in between this young adult age group and the elderly age group, it is advised that people should use their back responsibly. You should learn to carry objects so that you don't predispose yourself to lumbar disc herniation. There is an overall lifetime chance of having a lumbar disc herniation for everybody of 10%, and there is a male preponderance of 3:1. It is more common at L5-S1, with over 95% of cases of lumbar disc herniation occurring between L4, L5, and L5-S1 together. Diagnosis is mainly clinical, and you only need an MRI for confirmation, particularly when there is a disc herniation. It is not all cases of, particularly when there is a nerve irritation or compression. It is not all cases of disc herniation that will cause nerve compression. So you do the MRI, you request for an MRI for confirmation when there is a disc herniation compressing the nerve root. Dynamic studies will be requested for, in which case you do a flexion and extension study when you contemplate surgery, in which case you want to know whether you'll be doing a fusion for the patient or you just do a straightforward disc excision. It is important to remind ourselves of these principles, in this basic anatomic principle, to know where to approach the nerve and what nerve root is being compressed. The first is the pedicle nerve root mismatch. We know that there are 31 pairs of spinal nerve root. The C1 nerve root comes out between C1 and C2. Rather, the C2 nerve root comes out between C1 and C2 vertebral body, while the C6 exiting nerve root comes out underneath C5. There is an equilibrium at C8 because there is no C8 vertebra, but there is a C8 exiting nerve root. So there is a mismatch at the cervical spine. But at the lumbar spine, the L4 exiting nerve root comes out underneath the L4 pedicle. So there is no mismatch at the lumbar vertebral spine. Also, the second point is to note the vertical orientation of the exiting nerve root. You can see the image below. You can see the image below that the exiting nerve root at the lumbar spine exits almost vertically, while that at the cervical spine, the upper picture, you can see the exiting nerve root comes out almost horizontally. So a disc herniation at C6, for instance, will affect the exiting nerve root at that level, while a disc herniation at L3 will not necessarily affect the lumbar exiting nerve root of L3, but the traversing nerve root, because the disc that herniates comes out after or below the existing nerve root. Also, it's important to know to be able to differentiate axillary versus shoulder herniation. If you look at the image below, the external nerve, the external nerve is right above the disc that herniates. It's right above the disc that herniates. This is an axillary type of herniation, and the patient will shift to the other side. However, if there's a shoulder herniation, the patient will shift to decompress that foramen by moving to the ipsilateral side. For radiculopathy and radicular pain, it's important, particularly for residents, to know that radicular pain is different from radiculopathy. Typically, radicular pain is pain that shoots down the path and the back of the leg, almost always below the knee. If the pain does not go below the knee, it's almost always as a result of hamstring tightness from spondylolisthesis of the lumbosacral spine or lumbar spine. Radiculopathy means a pathology already in the nerve root, in which case patient presents with either paralysis, patient presents with numbness, and patient presents either with foot drop as well. 60% of patients will get better with non-surgical treatment, 60%. The non-surgical treatment have been described earlier: physiotherapy, medications, and steroids, all kinds, either particulate or non-particulate steroid. There was a study that was done by Chu et al., and it was a systematic review that was published in 2015. They found out that there was spontaneous regression of herniated disc tissue, particularly when there is a disc extrusion and sequestration, and less so when there is a disc protrusion. So patients with disc extrusion and sequestration, you can almost always invariably expect them to have a spontaneous regression. And this was also corroborated by a study that was done and published in 2014. It was a literature review by Mohamed Maki et al. And they found out that patients with sequestration have a very high chance of a regression or resorption of the disc, and less so with protrusion and extrusion in their own case. And the mechanism for that was an inflammatory response that is elicited against the free fragment. Surgical treatment has also been described extensively this morning. It can be the conventional open discectomy. It can be a micro discectomy. A lot of us do mini open, particularly in developing countries. You can position the patient in knee chest position, a 90-90 position in which the hip is in 90 degrees and the knee as well is in 90 degrees, just to open the interlaminar space. You can also do it with microscope with a tube, and it can be done endoscopically. A lot of complications, and I will just talk about a few common ones. And the most common that we see and that presents as some headache for the spine surgeon is the recurrent or persistent symptoms. This is seen in almost 20%. So if you're operating on 100 patients, you see 20 of them presenting with a recurrent or a persistent symptom. Dural tear can also occur. Nerve root-induced hyperalgesia has been described extensively. Infection and iatrogenic instability also can be seen. There is this debate of how much disc we remove each time we do a discectomy. Some people have said when you do a posterior normal conventional discectomy, either endoscopically or with a microscope, you don't remove as much as 50% of the disc, compared to when you do it through an A-leaf approach, anterior approach, in which case you can remove as much as 90% of the disc material. By way of operative approaches to the lumbar disc, a systematic review was done by Mohamed Ali et al. In 2018, and they found out that an open discectomy and tubular discectomy, which is a micro discectomy, was associated with a worse ODI scores compared with other approaches. And of course, they had significantly longer duration of stay and more blood loss. In terms of complication, tubular discectomy was found to be associated with a greater rate of overall complication. So by way of recurrent herniation of the nucleus pulposus, it is said to be more common than most of the complications that we see in lumbar disc surgery. Is this a reherniation or an incomplete discectomy ab initio? Most authors are divided in their opinion on this. And it's almost always the reason for reoperation in a lot of these patients. And second to that is an iatrogenic instability. A sports trial that was done shows a 15% revision rate at 8 years after the first discectomy. The recurrent herniated disc can be ipsilateral or contralateral. A lot of time you do discectomy for lumbar disc extrusion or sequestration, and you found the patient complaining of pain on the contralateral side. Is not unusual. It is rarely due to an adjacent disc herniation. Sometimes you do a disc herniation at L4, L5, and a few months down the line, there is either a superadjacent or a subjacent disc herniation as well. So about 3 to 20% of cases would have it, and more often than not, we start treating them non-operatively. Either you brace them up, or we give them non-steroidal anti-inflammatory agent, and also. However, after a recurrence, the patient is at a very high risk of further recurrences. Revision discectomy with or without fusion for treatment of recurrent lumbar disc herniation. There was a study that was done by Angelica in 2017, and it was revealed that older patients that had disc herniation with comorbidities are more likely to have a revision discectomy. So they found out that if you operate on a disc extrusion or sequestration in very old patients that have comorbidities, there is a strong chance that these patients will come back within 3 months. The majority of them will be seen within a year for a revision surgery. And this was corroborated by a study that was done by Ashraf Dawa in 2016. They found out that there is no evidence to recommend the routine addition of instrumented spinal fusion, because a lot of times you find surgeons saying or arguing that should we have done an instrumented fusion ab initio at the time we're doing a discectomy, even when there is no instability. So there was no evidence to recommend routine addition of instrumented fusion in the management of recurrent lumbar disc herniation. The data, however, suggests that minimally invasive discectomy has lower complication rates than a conventional discectomy in the setting of recurrent lumbar disc herniation. Again, Panagiotis et al., they compare the outcome of fusion versus repeat discectomy for recurrent lumbar disc herniation. This was published in 2018, and their conclusion was that available evidence shows that in treating one-time recurrent disc herniation, either you do a repeat discectomy or a fusion, they are associated with a comparative reoperation rate, incidence of dural tear, and functional outcome, as well as satisfaction with surgical treatment at follow-up. Jian Guan in 2016 compared clinical outcome of repeat discectomy versus fusion, and they concluded that repeat discectomy and instrumented fusion at the initial stage, they have similar clinical outcome at short-term follow-up. For patients that have a repeat or a recurrent lumbar disc herniation, would you rather opt for a fusion, or you just do a repeat discectomy? Shaswar et al. In 2020 published their own study. It was a systematic review, and they found out that neither discectomy nor fusion was superior. There was no statistically significant difference in the two. So if you opt for a fusion or you opt for a repeat discectomy, both would give you similar outcome. Surgical site infection was also seen in a quite number of patients. For our series, we found only 4 patients out of 78 that we did over a period of 2 years in Kano, Nigeria. And studies have shown that most patients that had it, the microscope that was placed in the patient or that was used in the theater was implicated. If the infection is superficial, antibiotics alone should suffice. However, if there's a deep infection, you would need to do an incision and drainage to debride the infected tissue. It can be more likely seen in patients with immune paresis or patients with diabetes and other comorbidities. Pyogenic spondylodiscitis is associated or seen in patients that have direct inoculation of the organism at the time of the index surgery, and is seen in 2 to 3% of cases. Immune paresis, comorbidities, and obesity are important risks to note, as well as smoking. These are important risks to note in the development of pyogenic spondylodiscitis. And what you do is similar to what you do in patient with surgical site infection. Arthrogenic instability is an important complication to note. A lot of time, you ask yourself how much lamina of the superior vertebra and the inferior vertebra should you take, and how much inferior or superior facetectomy should you do. All these would compromise the integrity of the spinal column at the level you're doing the discectomy. So overzealous resection of the lamina pass and or facet, particularly for patients, you do a superior facetectomy in patients that you're doing an endoscopic transforaminal discectomy for. These have been found to be responsible for arthrogenic instability. Almost always you miss it at the index case. Patient present 3 months later with continuing pain, worsening pain, and you do an X-ray, either a dynamic X-ray ab initio, or you do a plain X-ray and you realize that there is a slip at the level where the initial discectomy was done. This patient can be braced up if they are younger. However, if they are older, fusion is advocated at the first time. Ahmed in Egypt, Ahmed and Hafiz et al., they found out that arthrogenic instability may result from large laminectomy and extensive facetectomy for lumbar stenosis in patients who do not have obvious pre-existing instability. Dural tear is also quite common, particularly for those in the endoscopic discectomy group, as well as the micro dissectomy group, and relatively fewer cases are seen in the conventional discectomies. It should be identified and repaired at the time of surgery. Sometimes we give this patient acetazolamide as well as bed rest, and if they have persistent headache, we can give them caffeine. Sometimes we give them caffeine-containing drinks in the mornings, and this helps. This has been shown to help them in dealing with headaches. By way of take-home message, it is important to note that complications are seen infrequently in lumbar disc herniation. It's probably the most common surgeries that is done worldwide. Recurrent or persistent symptoms, dural tear and nerve root injury are seen more in patients with this that has had surgery for disc herniation. Many of the complications are amenable either to medical care or surgical treatment. Proper patient selection, excellent surgical skills, and rich experience of the surgeons are required for a satisfactory outcome. I wanted to show you a picture of my country. This is the federal capital. It is called Abuja. It's a beautiful view. I'm sorry, the picture is quite blurry, but you can see the mountain ranges all over the places in Abuja. It's a beautiful place, and I welcome all of you to visit us in Abuja. Professor Atiku Zaman should be visiting sometime in August. You're all welcome. It's a beautiful country. My people are very welcoming. We have very good food, as spicy as the food you have in Pakistan. The weather is very clement, almost similar to the weather in Pakistan. I wish to thank Professor Amar Aziz for providing excellent leadership. He's been a mentor of mine for the past 6 years, for mentoring generation of spine surgeons in the Middle East and North Africa, and West Africa by extension, because quite a number of us have come here. And we thank him profoundly and most kindly for providing this kind of platform for us to learn and to continue to learn. May Allah subhanahu wa ta'ala continue to be with him and bless the works of his hand. Also, I'll extend my gratitude to Dr. Maman Mohammed Lawal, he's my medical director. I want to thank him for releasing me to come for this experience. He is also a proud alumnus of Ghurki Trust and Teaching Hospital. He released me and he continues to pay my salary. I'm grateful to him. Dr. Kabir Abubakar is the president of the Nigerian Spine Society. We hope that in months and years to come, there will be a healthy collaboration between the Nigerian Spine Society and the Spine Society of Pakistan. I thank you all. Shukriya.
Thank you, Dr. Muttalib, for your very elaborative presentation. Now I request, can you please unshare your screen? Dr. Muttalib?
Yeah, done.
Okay. Thank you. Thank you. Dr. Mazhar, are you listening? Dr. Mazhar, can you start your presentation?
Yeah, I'm listening to you.
Okay. Please share your screen. Yes, your screen is on.
Yes, sir.
You can
Just
start
started.
slideshow.
Yes,
No problem. Take your time.
Bismillahirrahmanirrahim. Thank you very much, Dr. Pasha. My topic is imaging and treatment of the thoracic disc. All the previous talks were about the lumbar disc herniation. Before I come to the imaging and treatment of the thoracic disc herniation, I will quickly go through the rare facts, natural history, and the clinical presentation of the thoracic disc herniation. Herniated thoracic discs are herniated. Sir, you are listening me? Hello? Hello? Hello?
Hello, yes, we are listening.
Okay,
We
sir.
are listening you, Dr. Mazhar. We are listening you.
Okay.
You can
Okay, sir.
carry on.
Okay. Herniated thoracic discs are rare in comparison with herniated cervical or lumbar discs, comprising only 0.25 to 1% of all the herniated discs. Symptomatic herniated discs in the thoracic spine occur infrequently. Those who receive the surgical treatment that amounts only 5% of all the operation on herniated discs at the level of spinal column. Low incidence, a lack of appropriate knowledge about the disease natural history, diagnostic difficulties, and the variety of options for surgical treatment make herniated thoracic disc a controversial subject. Men and women are affected in equal proportions. The majority of the thoracic herniated discs occurs centrally or posterolaterally. Only 10% are true lateral. The vast majority of herniated thoracic discs are found below the level of T7. That may be because of towards the thoracolumbar junction. Between 13 and 70% of herniated thoracic discs are calcified. And this finding deserves attention because 5 to 10% of these cases are associated to intradural extension. Here we can see the axial and the sagittal view where there is intradural extension. No characteristic pattern of clinical presentation that distinguish a herniated thoracic disc from other lesions in the thoracic spine. But the most commonly encountered preoperative signs and symptoms are pain that may be localized, axial, radicular, motor impairment, that is myelopathy, hyperreflexia and spasticity, bowel and bladder dysfunction. On graph, we can see that localized pain is 70%, myelopathy 60%, hyperreflexia and spasticity 60%, and bladder and bowel dysfunction is 25%. Myelopathy associated with thoracic disc herniation is generally progressive, and in the center herniation, often it is accompanied by the sensory disturbance below the level of compression. When the disc fragment is lateral, it can often cause a radiculopathy characterized by pain in the dermatome of the root, which can be associated with the paresthesia or dysesthesia. And this radicular pain is more in the night. Imaging studies about the thoracic disc herniation. Imaging studies of thoracic region of the spine can be more difficult to analyze as it is contained within the thoracic cavity beneath several layers of tissue of varying density. In the past, myelogram was the examination of choice for diagnostic of thoracic disc herniation, but subsequently it is replaced by the CT and CT myelogram. CT myelogram, we can see in the images, there is a central disc herniation. But MRI has emerged as the primary imaging modality and gold standard in the evaluation of thoracic disc herniation. MRI provides detailed information about the herniated disc and the intruding spinal cord injury, including the chronicity. But we may need in some cases CT because CT is needed to evaluate the degree of calcification of the herniation and also important to distinguish between the disc calcification and disc ossification. And this particular feature of CT has important implications for surgical planning purposes. Here we can see the MRI, which shows disc herniation and the myelomalastic change in the cord. If we look sagittal section of the MRI. So what can be the natural history? Small, that is up to 3 mm, and the medium size, that is 3 to 6 mm thoracic herniated discs retain the same dimension in 85% of the cases. The larger one decrease in size, that is about 60% of the cases. The natural history indicates that herniation maintain or decrease their original size in the majority of the cases, thus establishing conservative treatment is the first therapeutic option. Here we can say there is a disc herniation, and after 1 year, almost complete resorption of the disc. What can be the conservative treatment in lumbar disc herniation? Most of the faculty has talked about this. That is the analgesia, gabapentin, pregabalin, tricyclic, antidepressant. The use of corticosteroid is controversial, but can be given for the progressive motor deficit or uncontrollable pain. Immobilization have some role. Thoracic support vest is an option that can present an analgesic effect and can relieve pain to some extent. Treatments such as external traction or osteopathic manipulation don't usually result in improvement. Adjuvant treatment as analgesic physiotherapy, acupuncturing, and similar therapies appears to be reduce pain, but they can't be associated to the general prognosis of the clinical course. What are the indications for the surgical treatment? Uncertainty about the natural history of the thoracic disc herniation makes it difficult to appropriate surgical indication. Prophylactic surgery should be avoided, and the most accepted indication are those where the patient presents with the progressive of sign and symptoms for more than 6 months, or severe myelopathy or radiculopathy. Surgical treatment should be considered for cases classified as grade 3A in the Regan classification. That is significant axial or radiculothoracic pain are more than 3A, 3B, 4, and 5. We should consider the surgical treatment, that is the decompression. Surgical approaches, there is no universally accepted selection criteria to help surgeons when choosing the most appropriate surgery for a given patient. Pre-operative planning based on the location of the disc herniation, that may be central, posterolateral, or two lateral. Then the anatomy and characteristic of disc herniation, it is calcified or ossification, is essential to successful surgical management. Early attempts at surgical treatment of thoracic disc herniation demonstrated limited efficacy and high rates of neurological compromise. The limited space available for the spinal cord in the region and decreased vascular supply increase the likelihood of injuring the spinal cord during decompression. So it is important to emphasize that the thoracic spinal cord cannot tolerate any degree of retraction, a lesson learned the hard way by the early surgeons. New thoracic spine approaches routes have been developed in recent years, offering better access to the ventral spinal canal and the disc space. As surgeons familiarize themselves with these type of access, they have more options when selecting the most appropriate for each patient. We have these approaches: posterior approach, posterolateral approach, that is costo-transversectomy, transpedicular approach, transfacet approach, that is called pedicle sparing approach, lateral extracavitary approach, and lateral parascapular extrapleural approach. Then comes the ventral approach and thoracoscopic approach. The most influential factors in the choice of surgical approach are level of herniation, position of the herniation disc, penetration in the dura mater, consistency of the disc, need for fusion, physiological age of the patient, the surgeon familiarity with each approach. I will not go in detail. This is the posterior approach, not approach of choice. because simple laminectomies had not a good result. Some surgeons performed simple decompression with removing the disc to avoid potentially harmful effect caused by the manipulation of the spinal cord in order to reach the ventrally positioned disc. Utilize attempt to reach the disc material by the intradural route by sectioning the denticulated ligament and performing rhizotomy. Significant high rate of post-operative neurological deficit following laminectomy for the treatment of herniated disc is apparently due to a combination of vascular insufficiency and the microcontusion secondary to the spinal cord manipulation. In posterolateral approach, we have a good access for ventral pathology and avoid the need of dangerous spinal cord manipulation associated with the direct posterior approach. In costotransversectomy, we remove the ribs head and transfer process, which have a wider view to go for further. Here we can see pre-operative and post-operative beautifully decompressed. Transpedicular approach. Transpedicular approach involves removing of the all pedicle caudal to the disc herniation as well as the facet joint. Affords more direct exposure of the ventrally positioned pathology. The potential for preserving radicular vessel is considered an advantage of this approach. Lateral extracavitary approach. This requires extensive dissection and manipulation of the soft tissue, including the paravertebral muscle, which can be denervated and devascularized. Lateral parascapular extrapular approach, that is good for thoracic disc herniation above the level of T5. Ventral approach. From an anatomical standpoint, the ventral approach offers excellent spinal cord exposure with an optimal angle of removing intradural disc and repair the dura mater. It also provides access at multiple levels. The above risk of this approach is causing pulmonary morbidity and damage to the large vessels and the viscera. But the use of this ventral approach is known to be limited in cases of herniation below the level of T5. Thoracoscopic approach. The use of video-assisted thoracoscopic surgery proved to be effective in the treatment of herniated thoracic disc with reduced mobility in relation to the classical ventral approach. Post-operative surgery have a resolution of symptom in about 87% of the cases. Complication, it is already discussed, almost have the same complication. Future prospects. The result achieved by surgery on herniated thoracic disc would be improved through more detailed knowledge of their natural history, which in turn is attained by studying unoperated asymptomatic and symptomatic cases. Advances in surgical technique will be consistent with the development of less invasive procedures that facilitate disc decompression, incorporating greater safety as well as reduced blood loss and post-operative pain. In summary, symptomatic herniated discs are relatively uncommon in the thoracic spine. Between 30 and 70% of all the thoracic herniated discs are calcified. The most common signs and symptoms are pain that may be axial or radicular, myelopathy, bowel and bladder dysfunction, hyperreflexia, spasticity. MRI imaging is the complementary study of choice. Surgery is indicated for progressive or severe symptoms of intractable radicular pain or myelopathy. Anterior or ventral approaches are recommended for midline herniation. Posterior approaches, mostly posterolateral, should be considered for lateral herniation. Thoracoscopy is an emerging treatment option for thoracic disc herniation. Thank you very much for your patience.
Thank you, Dr. Mazhar, for your very good talk on imaging of thoracic disc and treatment. Although it was not typically included in the lumbar spine, but thoracolumbar spine, since it is dealt usually in one topic, so and we have to cover one topic in this webinar, so that's why I assigned you some sort of different topic than the lumbar disc. Anyhow, it was very good presentation. Now I request all the presenters to unmute their mic and so that we can go into question and answer session. You are unmuted. I will request Professor Naik,
Yeah,
Professor Khalid, Professor Amjad, and Dr. Farooq, because the question answer session will go. Dr. Farooq, are you online? Dr. Farooq? Dr. Amjad, Sir Amjad, are you online? Okay. So first question is differential diagnosis of radiculopathy. Dr. Farooq, are you online?
Yeah, he just stepped out.
Dr. Farooq? Okay. We will ask the question regarding the presentation of Sir General Amjad Iqbal, that there is any role of hyaluronidase in ESI? Just I will sir, can you unmute your mic, Sir Amjad?
Can you hear me now?
Yes, sir, we can hear you now. Please tell us the role of hyaluronidase in ESI. This question was asked by Dr. Waqas.
Yes, hyaluronidase can be mixed with the epidural injection when in a chronic low back pain, where especially post-surgical, where we are expecting adherence around the nerve roots. So hyaluronidase have a role to reduce the adherence.
Okay. So do you have got any personal experience, or you are talking about literature only?
No, I haven't used it, but people who are doing this endoscopic adenolysis with the RAX catheter, they are using this in Pakistan. Certain people, they are using hyaluronidase during adenolysis through a RAX catheter.
Okay. So there is another question from Alivo Yukabu. It is also pertaining to your talk, Sir Amjad, that do you have any consideration regarding particulate or non-particulate steroid depending upon level of spinal cord?
Yes, the particulate, the danger of giving particulate this steroid is that if accidentally they are injected into some vessel, so they can block the vessel. They can cause damage to the spinal cord. On the other hand, they have a longer effects. When these are given, we can safely give in the lower lumbar spine. These particulates, they get attached to the inflamed part of the nerve root and causes have a strong anti-inflammatory effect, and effect is prolonged. Anti-inflammatory effect is prolonged. Whereas dexamethasone, which is also recommended, it has a short duration of action. In cervical area, we prefer to give dexamethasone, and in lumbar spine area, we prefer to give this triamcinolone or dapamedrone. I hope I've answered his query.
Yes, I think. And there is another question from Dr. Rizwan that is there any advantage of hyaluronidase mixed with steroids?
Yes, people, there are studies that people mix hyaluronidase with the steroids and for adenolysis purpose. Not as an anti-inflammatory effect, as a adenolysis purposes.
Yes, I know that you do radio frequency ablation for facet pains and things like that. But does this radio frequency ablation has got a role in discogenic pain? There is one question regarding this. Discogenic pain.
Yes, certain people, they are just using this RF in the disc for the disc ablation. They give this intradiscal RF, doing intradiscal RF therapy, but not over the nerve root.
So that is like a IDAT, intradiscal electrotherapy and things like that.
Yes.
So that is separately a different topic. And
yes, that's
that has not proven the test of time.
No, but it is not recommended over the nerve.
Yes, okay. So the next question is to Dr. Anayatullah. Dr. Anayatullah, can you unmute your mic?
Yes.
So there is
Yes.
a question from Dr. Mahmood Ahmed that what is the rate of disc herniation after micro dissectomy?
It is about 3 to 4% in our studies.
Okay. Okay. And there is another question regarding this micro dissectomy. This how to approach a severe symptom after dissectomy when post-op CT X-rays shows no abnormality and MRI contrast is insignificant and infection markers are also normal. Means if all the investigations are normal and patient is still feeling pain, how to approach that?
You can give a shot of steroid, long-acting steroid, just as a depometrol, and you can consider some analgesic. Mostly they will respond to this sort of there, but it's very unusual if you have done your surgery properly and you have decompressed the nerve root. So the chances of having pain after proper microdiscectomy is very a remote possibility. But still, if the nerve root is ischemic, so you can consider different type of analgesic and steroid.
So probably one of the cause is this, that as I have mentioned in my talk, that nucleus pulposus is a remnant of sort of notochord, and it remains away from the immune system of a person throughout its life. And when it's come into the canal, it is severely immunogenic. Even some surgeons, they put some steroid after operation there and then. Do you have any experience of that?
My practice is I usually put some Decadron, about 4 milligram, at the end of the procedure with the concept that it will really remove any inflammation around the nerve root, and it also decreases the chance of fibrosis around the nerve root, according to some papers. So, but to be honest, I haven't found any significant difference in between two groups, whether I put steroid or not. But some papers say there is an advantage.
So what is the concern of any sort of decrease immunity locally or increase in the infection rate after putting steroid? Because there are people who say that if you put steroid, there may increase the chance of infection. Is there any concern regarding this?
Whether I put steroid or not, I think we should be more careful about and we should pay special attention to cleaning and draping, and also theater environment. I think if there is too much pain after going through later on after microdiscectomy, you should go into the patient whether patient has got any psychological problem. So you should say a psychiatric problem is one of the problem.
Okay. So the next question also, I think pertaining to your talk is, does shape of herniated disc affect decision making of surgery?
No. In microdiscectomy, whether it's central or lateral, it doesn't make any difference. As far as endoscopic is concerned, as Professor Khalid Mahmood said, with the time, if you have done a big number of cases, even then, I used to take central disc with the endoscopic technique as well. So it doesn't matter for me now. But people, for newcomer, endoscopic is usually should be used for lateral. Later on, as they get experience, they can take out central as well.
Yes, that is pertaining to the surgical techniques, but I think the presenter, Dr. Vakas want to ask that if we see the what is the decision making of surgery, extrusion, protrusion, and things like that, that affects any decision making of regarding to go into surgery or not, or only clinical sign and symptoms they decide whether you should go on surgery?
Sometimes patient express their wish. They have seen the internet. They want to do endoscopic. So I respect their wish. But mostly I do microscopic. Sometimes I do endoscopic.
Dr. Vakas, actually, the shape of herniated disc does not affect decision making in surgery. The surgical indication for lumbar disc, they are absolute and relative. There are two absolute indication for surgery in lumbar disc extrusion or protrusion or whatever, because as we know, it is not the type of disc prolapse which affects the clinical symptom. It is also size of canal. If the canal is wide, more than 13 millimeter in AP diameter, there are lesser chance that you will get symptoms than in a congenitally stenosed canal. If you have got canal less than 10 millimeter, so it is the symptoms which will decide whether you are going to go for surgery or not. And all the presenter, they have elaborated that very fully, that cauda equina is absolute indication for surgery. Paresis less than MRC grade 3, it is absolute indication for surgery. Pain resolving not within 6 weeks, and with radiculopathy and imaging, they are convinced that your level is okay. That is another indication for surgery. And disc prolapse in face of narrow canal, that is less than 10 millimeter, and which is not resolved within, say, 6 weeks, it is another indication of surgery. Okay, Dr. Khalid, are you online?
Yes, I am. I'm online.
Okay, sir. Yes, sir. Achha, sir, but the next question is regarding your talk, that how much disc material should be removed in disc protrusion?
As much as you can. As much as you can.
As much as you can. Yeah. And how you will decide that how much you can?
Well, when you put the pituitary rongers and whatever comes out easily, you should remove it. Obviously, the extruded fragment very easily come out. You enter into the disc space straight, and whatever comes out easily, you can do it. You can put the curved one if it's a central disc prolapse to the opposite side. You can put the curved one to the ipsilateral side. So whatever comes out easily, you should remove it. But you should not be extensively scraping the end plates, right?
Yes.
Because
yes.
That would cause the discitis.
Okay, so now you want to say is that standard is that whatever is loose fragment or whatever comes easily, you should come out.
Just come out. But a lot of people, the degenerate part is the first one to come out very, very easily, right? Then you can put all sort of curved pituitary rongers and remove as much as you can, but without actually scraping against the end plates, because you cannot remove the normal or slightly degenerate disc. It's very difficult. And one of the reasons of persistent symptoms after surgery is the wrong indication for surgery. Because if you start entering into a disc, which is only a degenerate without any obvious neurological symptom signs or any protrusion, and when you scrape away, it causes a lot of inflammation and irritation of the root afterwards, and the patient gets worse. So you should be very clear about the diagnosis, and whatever you can remove, whatever you comes out easily, you should be removing
it. There is another question that it is also from you, Dr. Khalid, that patient having radicular symptom, but MR shows type 2 mordic changes. Does you advise fusion in this case or do simple dissectomy?
No, just simple dissectomy. My indication for fusion would be instability. My indication for fusion would be instability. Or if there is a spondylolisthesis, you can add a TLIF with that, right? But I don't go for routine fusion.
So you want to say if the patient is having a lot of back pain, instability pain, pain on turning, axial pain more, with radicular pain, and with these modic changes, and then of course modic changes with the facet of fusion and signs of instability on flexion extension radiographs, then you will add on fusion in this case.
Yeah, I think my absolute indication for the first go for fusion would be the instability. But if it's a recurrent disc prolapse, or if the patient has a very bad persistent when the backache is more than leg pain, for the redo surgery, I would like to add the TLIF.
Okay. So would you like to first redo or second redo?
No, first redo. First redo. Okay. You have done the first bit. If there's no instability, if there are very bad modic changes, no problem. You just do the routine endoscopy or microscope discectomy. If the patient comes back with a very severe backache, or if the patient has a discitis that he has recovered from, or there is a recurrent disc and with a lot of backache component, then I would like to add TLIF with that in any re-exploration.
Thank you. Next question is for Dr. Mazhar Ali. Is Dr. Mazhar, are you online? Can you unmute your mic, please, Dr. Mazhar? Dr. Mazhar, please unmute your mic.
Yes, sir. Yes.
Okay. Okay. Question for you is from Dr. Mushtaba, and he asks that what is difference between calcified and ossified disc, and what's its impact on decision making in thoracic disc?
Yeah. Yes, calcification is basically the peripheral mineralization, and thank you very much for Mushtaba for asking this question. And the ossification, there is complete bony remodeling. And what are the implications for the decision making? Because when the disc is calcified and giant disc, you should have to, it is centrally located, you have to go through the ventral approach. You can't go through the posterolateral approach. That is the main implication.
Okay, thank you. Dr. Amjad, Sir Amjad, are you online? Okay. So I think most of the questions has been answered.
Can I add to one thing? Can I add to one thing?
Yes, please. Yes, please.
I think the transthoracic discs are extremely rare. And if you are a busy spinal surgeon, you may encounter like 6 to 12 transthoracic discs in your lifetime career. I mean,
yes, totally agree.
Yeah, I have done maybe a dozen of thoracic discs, and I only do one approach, and that's a transthoracic discectomy. I don't use any other approach, and I think
yes, sir.
They're very good results for that.
Yes, sir.
Yes,
sir.
I think you are right.
Yes, sir. Sir, it is, yes, sir. So that's why it accounts only 0.25 to 1% of all the thoracic, all the herniated discs in the cervical, in the thoracic, and in the lumbar spine.
Yeah,
you are very right in this sense.
Yes. I have seen people doing laminectomy and retracting the cord and destroying the facet and going the transpedicular approach. I think the safest approach is the transthoracic approach.
Dr. Khalid, yes.
You're right, Dr. Khalid.
Yes, as mentioned by Dr. Khalid, it is more safe. You just do the laminectomy. Don't play with the card through posterior approach. I totally agree.
I think, but Dr. Mazhar, you cannot decompress the disc from there. That is indirect decompression, and the compression from the front will still be causing problem to the patient. You can no, Dr. Mazhar, you can do surgery like you do calafong. You go from posteriorly, do a costotransectomy and go from the side. Don't retract the cord.
Yes,
go to a foramen, just like calafong. You do a lot of tumors and lot of sort of caries spine in like that. So you can do, especially in those cases where you have got some lung problem to the patient, because
Yes, sir.
transthoracic approach is going to have a large effect on thoracotomies and chest tube problems and like that. So in that
Agreed.
cases, you can proceed with Calafong approach because you are very familiar as a spine surgeon, and especially
surgeon.
orthospine surgeon and neurospine surgeon. They are very familiar with this approach. So you
Right.
go from side and don't retract the cord.
Yeah, can I add one thing?
Yes,
I
sir.
think
Yes, sir.
all the thoracic discs which I have encountered, you cannot remove with the pituitary rongers as you remove a normal disc. You have to
Yes,
actually.
yes, you cannot. You cannot. You use actually Epstein sort of reverse curate. You use Epstein curate, that is a reverse curate. You don't retract the cord. Just expose through like a Calafong approach. You go from the side, and with the Epstein curates, you slowly with the 0 curate or number 1 curate, you push that into the discal space, that all disc, and from the center you remove that.
Yes.
Yeah.
What cavity you create, you have to put the.
Yeah, you cannot compare the thoracic disc with the Carey spine. Carey spine is a different ball game. You know, material is soft. There is a pass. It just comes out. You go from the side. I really would advocate a transthoracic approach. You should. I mean, you cannot master all the approaches because it's a rare
Yes, sir.
scenario. I mean, I when I was being trained as a registrar in England, I assisted to my spinal surgeon about 4 or 5 transthoracic approach. And ever since over last 25, 30 years, I am doing transthoracic approach. I've done few costo-transverse approaches for the thoracic disc, and I have found it complication free. You should be very careful about the level because you can do the
Yes.
wrong level.
Yes,
Yes,
that's very,
yes.
very
Yes,
difficult
wrong
to find level.
Sir, wrong level is 10% in thoracic spine. 10%.
Yes.
And you should ensure that there are 5 lumbar vertebrae and there are 12 ribs. And
Yes.
also, you should actually, one of the cardiothoracic surgeon, he sort of showed us how to count from the first rib down. So different ways, you know, you
Yes,
confront with imaging A, and you perioperatively count from first rib down, and the sort of head of the lower rib would take you to the disc space. Like if it's a 6-7 disc space, so the 7th rib head would take you to the 6-7 disc space, and
Yes.
you
Yes.
remove the head and you go into the, because most of these thoracic discs, you know, they don't have radicular symptoms. They present with myelopathy. They present with paraparesis. So what you need to decompress is the central anterior part of the disc, and just without damaging the dura. I mean, you cannot do it without a microscope. You cannot do it with a drill. And it's an art, and it's a separate subspecialty actually to actually do a thoracic discectomy.
Oh,
Yes, well,
thank you.
100% agreed, sir.
Agreed, sir. Agreed. So I think now we are going to conclude this webinar. I am very thankful to all the presenters and the participants for taking, giving us an opportunity to share our experience with each other and learning from each other. I hope we will meet again with another webinar, and we will again learn from each other. Thank you, everybody.
Thank you.
And Allah Hafiz. Goodbye.
Goodbye.
Have a nice day.
Right. Thank you.
Okay, bye. Okay, bye, sir.